It is correct. Palliative care was not mandatory at Mount Carmel was.
I want to just go here to what's marked as Joint Exhibit 2, page 373. This appears, does it not, to be a palliative care consult for Ryan Hayes, correct, doctor?
It does, yes.
And I want to go again, these are my highlights. History and of present illness. If you could look here, what is the doctor name that appears there?
But that's not a doctor, that's a nurse practitioner.
Yes.
CNP, certified nurse practitioner.
Certified nurse practitioner. I'm sorry, but the name?
Chowan.
Okay. And then,
I'm sorry, Chauvin.
and then right here, does it not indicate, and if you could tell the jurors the time of the visit was what time of the palliative care consult?
The time was 2:30 in the afternoon
On what date?
on April the 2nd.
So the date that he arrives, he being Ryan Hayes, to Mount Carmel West, there is in fact a palliative care consult done.
I do see that, yes.
And and yet his course of treatment is through the 4th, right?
Correct.
And then you see down here, palliative care team was consulted to assist with the coordination of care.
That's correct.
Brother Ron at bedside,
True.
right? So I just want to go back then, Doctor, to this note where you indicate here on 7, we know that Dr. Husel was not working the day shift when the decision was made, but we also know, do we not, with respect to your finding as to number 7, that that's inaccurate.
That's correct. It appears a palliative care consult had occurred on the 2nd.
And then I want to go to your findings with respect to, again, Ryan Hayes, but now we're moving on to number 8. That the medical records did not include any documentation that Mr. Hayes' condition had deteriorated to a point where further medical or surgical intervention would have been unlikely to stabilize his condition. I want to go back to, and then further you talk about there's no cardiopulmonary documentation to suggest that this patient was terminal. You see that as well?
See that.
Doctor, remember on your direct examination, you talked quite a bit about the hypothermia protocol. Do you remember that testimony?
I do.
And that's one of the things that you indicated that could have been done to cool a patient.
Correct.
And when Ms. Scrub asked you about the actions or lack of actions, you talked about that cooling protocol as a way or a medical procedure intervention that could have been done by Dr. Husel that wasn't done in a number of instances. Do you remember that testimony?
That's correct, in a number of instances.
Showing you what's been marked is Joint Exhibit 2, page 22 to 27. Does this appear to be that Closser progress note that I had showed you previously?
Yes, it does, April 3rd.
And just for the record, just want to make sure, the progress note is page 22 to 27, is I have it marked for the exhibit. Doctor, want to go to page 26 of that progress note. That line I just highlighted right there with under cardiology. Would you agree with me that it says due to high pressure, and we know that's vasopressor, right?
That's true.
So the cardiologist, Dr. Closser, or Dr. Closser's pulmonary. The pulmonary doctor in the ICU notes, due to high pressure requirements, patient did not undergo hypothermia protocol. Do you see that?
Yes, I do see that.
And this progress note is from April 3rd?
Yes, April 3rd.
And the date of death for Mr. Hayes is the 4th?
Correct.
And would you agree with me that that is a daytime shift entry?
It is. It's 4:07 in the afternoon.
So with respect to Mr. Hayes, we know why why Dr. Closser found that he was not a good candidate for cooling. Is that right?
Yes, in regards to Dr. Closser, that was his entry.
It's noted on that medical record that he can't get that hypothermia protocol, he being Hayes, because of the high vasopressors. Do you interpret that through your work as an expert to mean that that was a, do you say counter indicator?
Contraindication.
Contraindication. And tell the jurors what a contraindication is.
A contraindication is when there is something in the patient's history or physical examination that would usually speak against offering treatment.
So here we've got him on vasopressors, no cooling, according to Dr. Clausen.
According to Dr. Clausen.
Just want to go now to, with respect to Ryan Hayes, your finding on 29. And I know you're talking about Dr. Husel here, but we know that the decision was not made by Dr. Husel or during his shift. But would you agree that at the end here it says at least a critical care medicine physician should not draw a conclusion with respect to futile without allowing a reasonable time to pass? And then do you see how you write greater than or equal to 24 hours?
Correct.
Just want to go back to, if we could, the history and physical, Joint Exhibit 2, page 12. This is done by Dr. Epen.
True.
Very first doctor that sees Ryan Hayes. Do you agree with me on that?
He was one of the first doctors to see him.
Okay. And he indicates here, the patient does not have any chance of survival. Do you see that?
I see that highlighted.
And then going on to progress note, Joint Exhibit 2, page 32, does this appear to be a note by a different physician?
It does.
And would you agree with me that progress there is noted to be terminal?
Yes, Dr. Vashani does indicate in his note, in his opinion, he believed the patient to be terminal.
I just want to go back to the history and physical. You would agree with me that 24 plus hours passes from this determination to when Mr. Hayes is palliatively extubated, correct?
That is correct.
Let's go to Ms. Belisari, if we could. I just want to, this is page 30 from your findings with respect to Ms. Belisari. And as highlighted here, you note it appears that he, being Dr. Husel, failed to clearly delineate that Ms. Belisari's status was not terminal, and further medical surgical interventions had not been exhausted. That's your finding with respect to 30 on Ms. Belisari, correct?
Correct.
Just want to go through, if we could, Joint Exhibit 1, page 127 to 128. You are aware, are you not, that Dr. Ralston is an ICU doctor?
I am, yes.
And does this appear to be Dr. Ralston's note?
Yes, from May the 1st.
And I want to go to, I'm sorry, that's May 1st
Yes,
is
May
his
the
note? And the patient passes on the 10th.
Correct.
So 9 days in between?
That's true.
This is Dr. Ralston's note, is it not? Critical care, 42 minutes.
Correct.
He writes, without ventilator or pressors, patient would die. Is that right?
His assessment on May the 1st was without that continued support of pressors and ventilators, the patient would die.
And that's page 128, right?
Correct.
Okay, and then the following day, showing you what's been marked as Joint 1, page 145, appears to be by Dr. Fagan. Do you see that?
I do see that.
Okay. And it looks like when addendum by, does that happen when there's a resident?
Correct. The attending is expected to authorize and authenticate the note and then put her or his supplemental addendum, which is what appears Dr. Fagan did in this case.
And this note appears to be on 5/2, is that correct?
Yes, May the 2nd at 9:40 in the evening.
So we have here, patient is on full life support measures without which she, being Miss Belisari, could not survive.
Yes, that is the statement.
And then, and I'm sorry, but Dr. Fagan, ICU doctor?
Yes, my impression of reading the charts was that he was the ICU doctor supervising the resident.
And then 6 days later, on May 8th, I'm showing you what's been marked as Joint Exhibit 1, page 250 to 251. Does this appear to be a progress note authored by ICU Dr. Moody?
It was authored by Dr. Moody. I don't recall if she was an ICU doctor or a hospitalist, but she did author this note.
Okay. Flipping to page 2 of that, indicates, does it not, that she spent 37 minutes with the family on May 8th?
Correct.
She notes the family expressed to me the fact that Miss Belisari is a very private and modest woman who had always expressed to them her wishes that she not be on life support.
Yes, that was in Dr. Moody's note.
And if you recall, this was on a Friday. Does that sound familiar?
I don't specifically remember which day of the week it was.
Okay, and then there's discussions right down here that Dr. Moody has about the vent withdrawal, changing the status. Would you agree with me on that?
Yes, and that does appear to corroborate that this conversation was on a Friday because they wanted to support her over the weekend.
So in this note, it's Dr. Moody that's having the conversation with the family, and it appears overall it was 37 minutes.
That's correct, from noon to 12:37.
And then I just want to go, if we could, to page 259 of the Belisari records. Do you see this separately with respect to where I've highlighted there is a high suspicion of malignancy? Do you see that?
Yes, I do see that.
Although the final pathology diagnosis is pending. The high suspicion of malignancy is that there was a suspicion that her cancer had spread.
Well, there was a specific suspicion that she had cancer, malignancy. The word spread would be metastases, which is not mentioned in the note.
Sorry, so there was a high suspicion that she had cancer.
Yes.
Now, going, and we know that you said when you talked about pain during dying, you told this jury on direct that those with cancer can often experience pain while dying.
Yes, that's a true statement.
Showing you what's been marked as Joint Exhibit 1, page 278, 279, with respect to Ms. Belisari. Does this, the date appears to be the same day that she passes, is that fair?
Correct, that was May the 10th.
So I want to go to the 10th because we have the notes, do we not, from the doctor about her being on full vent support from the 1st, the 2nd, the 8th, and I just want to close out with the 10th. Dr. Moody has indicated, has she not, that the patient is on full life support measures, including vasopressors and mechanical vent. And then the next sentence says, does it not, without such measures, she would not survive. Do you see that?
Yes, I do see that.
I want to go to a question that you were asked about in your deposition. If we could. And your deposition, when I say that, to orient you, I mean June 21st, 2021. When you were asked about the time someone that's on full vent support would expect to live once the ventilator is turned off. Do you remember those questions?
Correct. There was a series of questions regarding that topic.
And your answer was it not, well, I would answer that if the patient patient is fully vent dependent and the vent is withdrawn, then yes, in that patient, if they're completely dependent on gas exchange from the ventilator and the ventilator function of the ventilator driving the tidal volume, then they would not be able to exist more than 4 or 5 minutes without the ventilator.
That's correct. If they're fully vent dependent, that there's only a 4 to 5 minute oxygen reserve in the brain for the human body.
And I think you testified on direct that after she was extubated, she died 8 minutes later.
That's correct.
Just a couple other things with respect to Ms. Belisari, showing you what's been marked as Joint Exhibit 1, page 127, 313 to 314. Dr. Husel is the one that intubated this patient Belisari, is he not?
That's correct.
And we know that because of this note. Is that correct?
Yes, this appears to be the procedure note.
And so I want to talk about, if we could, one moment. Where's the intubation sheet? Yeah. I'm looking for the sheet. One moment, Your Honor. Just need an intubation sheet. So I will go to you talked about with respect to Ms. Belisari. Do you remember talking about the paralytics?
Yes, I recall that.
Oh, never mind. My mistake. I'll withdraw that question. I just want to make sure with respect to Dr. Moody's note on the 10th that I showed you that was the day that she passed, that she indicates, see my separate note regarding discussions reached during family meeting on 5/18/15. And do you see that the patient is now DNR-CCA?
That is correct. I see that.
And that, again, was a Dr. Moody note?
Yes, that's the Moody note from May 10th.
I want to just go back to something you testified to on direct, showing you what's been marked as Defendant's Exhibit Hans 19. If I heard your testimony right, and I just want to make sure, Doctor, that you said that she was not given Dilaudid during her stay at the hospital, that she was given a medicine called Precedex or something to that effect. Help me, if you would.
Precedex?
Yes. Fair to say, I'm showing you her medical administration record. Does that look like this is for patient Ms. Belisari?
Yes, this is the MAR, medication administration record.
Right. I just want to indicate there that on May 1st, she is given Dilaudid. Does that look true?
Yes, there was an order placed for Dilaudid on May 1st.
And we know, because we're looking at a MAR, that this means these medications were actually given.
Correct.
And then on the next page on 5/1, again, there appears to be an administration of Dilaudid.
That's correct.
And then on 4, and this is a infusion, is it not?
Yes, this is an infusion.
And the first one is an infusion too, so it's giving the medication on a continuous basis.
That's true. It's infused into the patient through her IV.
And then we have here on 5/4 that she's given another continuous infusion of Dilaudid.
On 5/4, the dose was increased.
The dose is increased from 1 milligram per hour to 2.
Correct.
And that's entered by Dr. Husel and Nurse Springer. Do you see that?
That's correct. The original order was placed by Dr. Husel.
So that's an example of fractured dosing. Increase is needed.
It's an example of incremental titration upwards, yes.
Increment. And then we have on 5.5, the Dilaudid, and it's changed on 5.5 to the medication that you had testified to on direct. Is that now does that help refresh your recollection, doctor?
Yeah, so this indicates that the Dilaudid has been stopped. It's gone to 0 in order for the other medication to be initiated.
So she was on Dilaudid while she was at the hospital and not just on the medication that you testified to.
That's correct.
I want to go to Mr. Timmons, if we could. You know what? Sometimes it happens. If we could go back to Mr. Hayes, doctor. Appreciate your letting me toggle back and forth. Defendant's Exhibit RH3. Mr. Hayes, you testified that after you had written your report on Mr. Hayes, you had an opportunity to review the coroner's report.
Yes, that's correct.
And hate to ask the obvious, but you are not a forensic pathologist.
No, ma'am, I am not.
And on this final report by the Franklin County coroner, the cause of death is listed as what?
The cause of death is hypoxic ischemic encephalopathy, which is synonymous with anoxic encephalopathy.
And the manner of death is marked as an accident?
It is, yes.
And then you've got the due to, and we show the resuscitated cardiopulmonary arrest, and then you've got the acute mix of drugs.
Correct.
Want to talk about those drugs. You remember that Mr. Hayes was the patient that was found in his bathtub by his sister?
That's correct.
And here in the autopsy report where it notes how injury occurred, it says what?
It says
Sorry.
Consumed carfentanil, fentanyl, morphine, and ethanol.
Then I want to go back to the toxicology that you testified to. You recall, I presume, that Mr. Hayes' stay in Mount Carmel West was April 2nd to April 4th.
Yes, that is correct.
And so then April 2nd would have been the day that he arrived at Mount Carmel West.
Exactly.
You were asked questions about the blood draw that was done. Fair to say this blood draw, as you now have come to understand the medical records, was done as soon as he arrived at Mount Carmel West.
Yes, it was obtained in the emergency room, apparently.
So this captures the drugs that he had in his system upon arrival.
Correct.
Your testimony about ethanol it's just noted there as point 110. You would agree with me, would you not, that norfentanyl is a metabolite of fentanyl?
That's correct.
But carfentanil is actually something distinctly different.
Yes, it's another semi-synthetic narcotic. It's a similar structure, but even more powerful than fentanyl.
Since you mentioned its power comparison, do you happen to know that carfentanil is 100 times more potent than fentanyl?
That is correct, yes. Usually it's not used in human medicine. It's primarily reserved in veterinary medicine for things such as elephants and zoos because it's so powerful.
It's like a tranquilizer.
Yes, exactly.
And so in this individual, if we could go up here, we have a positive for carfentanil.
Correct.
And also, we have a positive up here for what other drugs?
There was a positive for morphine, and then there was also a positive for naloxone, which is the reversal agent. And then it said positive for nicotine and cocaine.
And cocaine as well, is that right?
Yes, it was positive for cocaine. Again, they didn't appear to quantify that. They just indicated positive. Oh, I'm sorry, I take that back. Not cocaine. Maybe it was flipping so quickly. I think it It was codeine, which is the metabolite of nicotine, so nicotine and codeine.
So he's got carfentanil, morphine, some nicotine,
Correct. And alcohol.
and alcohol, and then he has fentanyl in his system.
That's correct.
And so when he arrives, if we could go back to how the injury occurred, those are the same drugs that are listed, are they not, as to the forensic pathologist findings as to what he had consumed?
That's correct.
Carfentanil, fentanyl, morphine, and ethanol.
That's true.
And actually, if you know, carfentanil isn't even allowed for use in humans, medically speaking.
Exactly. It has no use within the hospital or in humans.
Now, Mr. Timmons, thank you. Just want to start with your findings with respect to Mr. Timmons on paragraph 34, that his status was not yet terminal and further medical surgical interventions had not been exhausted. Do you see that as one of your findings?
Yes, I do.
Showing you what has been marked as Joint Exhibit 11, page 31 to 32. Does this appear to be a note from Dr. Ralston?
It is, yes.
This note is the day before Mr. Timmons passes.
Correct.
Just want to go at the top of that progress note that is authored by Dr. Ralston that notes, does it not, without the ventilator pressors or interventional critical care, patient would die or have organ damage. Do you see that note?
Yes, I do see that note.
And then further, it just indicates no family at bedside.
That is true.
Critical time of care that he notes there is over 2 hours that he spent with Mr. Timmons. Does that look right?
That's correct. He spent 2 hours and 1 minute caring for Mr. Timmons.
Then I want to go to what I'm showing you is Joint Exhibit 11, page 10. This is a history and physical done by a doctor upon Mr. Timmons' arrival.
Yes, that's correct. The admitting physician team.
This is on 10/23.
So Dr. Batashi signed it on 10/23. The note was generated by Dr. Sean Kim, who was the senior resident, I believe.
And Dr. Sean Kim's name is right down there. Would you agree with me on that?
Yes, that's correct.
Perfect, thank you for that. So, and that's why it says addendum by. So we have a physician overseeing the resident, as you discussed. So notes from, as approved by Dr. Batasti, indicate, do they not, that I have seen and examined the patient with Dr. Kim, and that there appeared to have been reviewed the lab data, vital signs, and diagnostic studies. Do you see that?
Yes, I see that.
And LLE is tight, there are no pulses, and poor cap refill?
Correct. LLE is left lower extremity is tight, and there are no pulses or poor capillary refill.
And this is from the leg?
Yes, the LLE refers to the left leg.
And then the following note is connected, is it not, where it says he's going to OR urgently for compartment syndrome, remains on pressors for shock.
True.
On CRRT? And
Yes.
if you could tell the jurors what CRRT?
CRT is continuous renal replacement therapy. It's continuous hemodialysis.
Because his kidneys are failing.
That's correct, due to the rhabdomyolysis.
And the note here by Dr. Bastati, assume he approved from Dr. Kim, is high mortality risk.
That's true.
I want to talk about this finding that you made with respect to Mr. Timmons, number 17. What does Haldol do?
Haldol is an antipsychotic that also has some sedative properties to it.
Doctor, would you like to review the MAR or the order set to see if Mr. Timmons was actually ever either ordered or given Haldol?
Yes, I haven't memorized the the MAR, so I'd have to look to see whether or not it was given.
Sure, we can come back to it because I know it'll take you some time. But perhaps at a break, I will, oh, here it is. No, this is, I will give you the MAR so that you can.
They're all in there. Every
Okay.
last one of them.
Okay.
You just have to flip it over into the right one.
Then I want to just go. I want to go to, while I circle back to that, I want to go to Mr. Timmons' autopsy report showing you Defendant's Exhibit JT3. As you recall, Mr. Timmons was the one that was found in his basement on an overdose. Do you recall that?
That is correct.
And the duration of the time for which he had been unresponsive in his basement, fair to say that was unknown.
That's true. It was documented to be unknown.
There was even a note that it could have been as long as up to 48 hours.
Correct. Based on the severity of his muscle injury, it was believed to be longer than 24 hours.
I want to show you with respect to his MAR, while I wait to circle back on the full MAR. On 10/22, he arrived at Mount Carmel West
Correct.
and just passed on 10/24.
Exactly.
Just want to show you, if we could, we know, or you know, based on your review of the records, that Mr. Timmons had a history of opioid use.
True.
And you also know that, based now on the review of the coroner's report, that he had tracks in his arm. Do you remember that?
Yes, the coroner did find evidence of both recent and remote needle tracks from injectable drugs.
Would you agree with me that the recent and the remote were probably injection sites that had healed over with some time?
True.
And so it was almost like a scar and more of an unscarred needle entry?
Yes, I would agree with you that it was a scar from prior needle puncture.
And then it also, the coroner's report indicated that there was a note that there had been recent needle use, correct?
Yes, there was also evidence that he had recently injected himself with drugs.
So I just want to, and I ask you these questions with respect to tolerance. He arrives on 10/22. On 10/23, do you see this order for fentanyl here?
I do, yes.
And this order right here is an order for 300 micrograms. This is an infusion order, is it not?
Yes, this is a continuous infusion of fentanyl.
And we know that because it, not only from this down here, but it says continuous infusions up there.
Correct.
The person ordering this,
Dr. Husel?
then this right here, we know later in the day on 10/23, tell us what happens with that fentanyl infusion.
So it appears later in the day that the fentanyl infusion is reduced by 50%. It's essentially cut in half.
And the ordering physician on that?
Well, it's attributing the original order to Dr. Husel, but this occurred during the morning at 10:45, so it would have been a different physician or team that would have triggered the reduction, unless Dr. Husel was still there. But you can see it's still attributing the original order to 8 minutes after midnight.
This is right here?
Correct.
The original order?
Yes.
And so then, at some point in the next shift, still getting fentanyl on an infusion base?
That's correct.
And then same, here is now 200?
Yes, at 8 o'clock and at 8:28 in the evening, the dose had been slightly increased from 150 micrograms per hour to 200 micrograms per hour.
And the HR just so that it's per hour?
Per hour.
You get that per hour?
Correct.
And when we see, doctor, an order, let's say here at 10:45, and then the order seems to be modified at 20:28, we can presume, can we not, that in those 2 hours in between, that person got the 150 per hour?
Correct, unless there's a specific note in the nursing orders that it's been held because of transferring the patient to test or OR, one could presume that the patient received the medication.
So I asked that because this original order here is like 12:44 a.m.
Correct.
for 300 micrograms an hour.
Yes, that's true.
And then the next time that medication is adjusted is at 10:45.
Correct.
So for approximately 10 hours, Mr. Timmons was receiving 300 micrograms of fentanyl.
Yes, again, at some point he did go to the operating room. I'd have to look back to see the exact time that he went to the operating room, but at least based on what's in the MARS, it would appear that he received the infusion at 300 mics per hour through that period of time until it was cut by 50%.
I think I have the operating room note. I will try to find it. But generally, principle 300 an hour means you get 300 every hour until either the order is discontinued or it's modified.
Yes, that's a true statement.
So then I'll go to Mr. Timmons, the autopsy done in this case. And like Mr. Hayes, this was an overdose situation as it came into Mount Carmel West, correct?
Yes, I would agree. He wasn't clearly an overdose case.
And cause of death as determined by the Franklin County coroner was what?
Recent cocaine and fentanyl use.
And then the manner of death is noted as?
It was described as an accident.
Wanted to just turn, if we could, to this page right here, how the injury occurred. The coroner in this case noted used cocaine and fentanyl.
That's correct.
And the word used is appropriate because, like with Mr. Hayes, this urine draw was done right when he arrived at Mount Carmel West.
Yes, it correlates with his time in the emergency room, and ante-mortem means while still alive. And again, the date of admission correlates with this draw.
And so just so that the jury is clear, I'll just show a progress note. He arrived on 10/22, and this urine draw is 10/22.
True.
And so in his urine, positive for fentanyl
Correct.
upon arrival at the hospital, and then positive for nicotine.
That's
you know,
true.
Just from smoking a cigarette, like.
Correct.
And then on page 2, it's positive for cocaine.
That's correct.
So let's discount the nicotine. The finding by the urine that when he arrived at Mount Carmel there was fentanyl and cocaine in the system explains, or at least correlates, with the finding that Mr. Timmons had used cocaine and fentanyl.
Yes, it appears that the pathologist and the coroners got that information from the ante-mortem urine specimen.
I think. Did I miss a ketamine finding?
Yes, I did see that when the urine was drawn, they did also detect ketamine in the urine specimen.
Right here.
Correct.
And tell the jurors what ketamine is.
Ketamine is a sister of LSD. It is able to be injected. It's used often in veterinary medicine and also in anesthesia and critical care to either induce anesthesia or to relieve bronchospasm in people that have bad asthma.
But like carfentanil, it's a drug that one would expect to see with animals and not with humans.
No, I mean, whereas carfentanil is never used in humans, we use ketamine selectively. It's more often used in veterinary medicine, but anesthesiology and critical care will use it with tremendous caution. But it is a drug of abuse, unfortunately. The last decade, people do abuse it on the street.
And that's showing as positive in addition to the fentanyl and the cocaine.
It is, yes.
For Mr. Timmons.
Correct.
I'm going to go to Miss Hodge, if we could. I can't find that in the sheet. 1 second. Oh, just where I left it. people have a filing cabinet, doctor, you know? So I wanted to just go back to, I believe that Ms. Grubb, or I'm sorry, the prosecutor showed you on your direct an order for fentanyl that was ordered and then showed to be administered to Mr. Timmons.
Correct.
And this will help answer two questions. You mentioned and this is the anesthesia record,
It is, yes. This is the electronic version of the anesthesia record.
indicating from page 3 of 4, but this does appear to belong to Mr. Timmons.
It does, yes. And you can see below that, it's the fasciotomy of his left leg where they took him to open his leg up.
Right, and so I wanted to just, because the time of his surgery, you indicated you just weren't sure. Does this help refresh your recollection as to 12:05, it says surgery start? Do you see that, doctor?
Yes, if you actually go up just a little bit, it'll show that at 11:44, he was transported from the ICU into the OR, and then the surgery started roughly 15 minutes later, as you had mentioned, at 12:05, and then it concluded at 12:41, or 12:34.
Yes, 12:41. So it looks like the surgery start and surgery stop is about 29 minutes. Does that look right?
Yes, that's exactly correct.
And I mentioned that in relation to my question about the MAR, whether, the fentanyl infusion, how that would be impacted by the surgery time.
Yeah, so looking at this, it does appear that during that period, he was receiving the fentanyl infusion.
And you were shown an order and a MAR that was correlated to the surgical procedure, which had an order of fentanyl for 14,321.2494. Do you remember being shown that documentation?
Correct.
I just wanted to be clear about, this is the anesthesia record, and that number purports to be there. Do you see that?
Correct. Apparently, the anesthesia team was reading that either off the infusion pump or somewhere else, because obviously one could not receive that much fentanyl in 30 or 40 minutes in the OR. So it looks like they were counting from what was on the pump.
Well, so I want to get to that. Do you agree with me that the next page on the anesthesia record indicates, and we know these medications were administered for the surgery, were they not? The midazolam, the fentanyl, and the propofol?
That's correct.
And those amounts, if you recall, the 3, the 30, and the 550 are all accurate?
Yes.
And then we've got that 14,000 microgram number of fentanyl repeats itself there on this anesthesia record as well.
Correct. And then embedded in that black line is a number which I could not read. Again, it's easier when you're actually looking at the electronic record, but you can see there's a number that was embedded in there.
And I just want to say here, the surgery time appears 12:05.
Correct.
And then here, we've got on this record, the fentanyl is 11:44.
True.
And then I want to just go back here to correlate it, that 11:44 is when it appears Mr. Simmons was taken in transport to have that surgery.
Yes, that's accurate.
So these, and that fentanyl, those orders, those administration of that fentanyl was not related to Dr. Husel. You would agree with me on that?
Yes, I would agree. Dr. Husel was not involved in delivering anesthesia to Mr. Timmons.
Let's go to Ms. Hodge. Ms. Hodge was a patient that actually, as she wheeled into the ER, she was having a code, was she not?
Yes, that's correct.
And I just want to go through something that you said on your direct examination with respect to the survival rate of individuals that are given CPR before they arrive at hospitals. Do you remember that testimony?
Correct.
And then you gave a different number to the jurors about the likelihood of survival when someone gets CPR within a hospital.
True.
Are you familiar with the National Academies of Sciences, Engineering, and Medicine?
I'm not a member. I've heard it referenced.
Showing you what's been marked as Defendant's Exhibit Hans 23. This article that I'm showing you appears to just be titled Cardiac Survival Rates, around 6% for those occurring outside of a hospital. Do you see that?
I see that listed in this paper. I've never seen this document before in my life.
And you haven't?
No.
I have provided it to the state, Your Honor. So my question about this is, would it surprise you to know that there was a study done by the National Academy of Science, Engineering, and Medicine that indicated that every year 395 cases of cardiac arrest occur outside of the hospital, so about 400,000?
That number doesn't surprise me. That's consistent with what the American College of Cardiology reports.
And then they further find in their study that less than 6% of that 395,000 survive.
You'd have to figure out what their marker was for survival. Was it leaving the hospital? Was it surviving 30 days? I don't know that specific study.
And that's certainly lower than the number that you gave, though, when you testified.
Correct. It's not consistent with other data offered by the American Heart Association and the American College of Cardiology.
So let's go to Ms. Hodge. Paragraph 29, you, again, kind of a repeating statement, but you've included with Ms. Hodge as well. It appears he, Dr. Husel, did not delineate Ms. Hodge's status. It was not yet terminal, and further medical surgical interventions had not been exhausted. So with respect to that finding, I just want to show you Joint Exhibit 7, page 19 to 21. We know that she arrived on April 1st.
True.
And physician note right here indicates which doctor?
That's Dr. Glucker, who is the emergency room physician that first took care of him.
Dr. Glucker seems to do the physical exam that you talked about in your direct. Does that sound right?
Yes, that is correct. That's documented on this page that you're showing.
And with respect to the cardiovascular findings that he makes, he writes that there are no heart sounds, right?
That's correct. When he listened, he did not appreciate heart sounds in the absence of CPR.
Then he further notes that femoral pulses are present with CPR. However, there are no palpable pulses when CPR is not performed. Would you agree that that's his finding?
Yes, I would agree that that's what he found.
Then immediately, treatment and medical decision-making. Patient is intubated by myself, see procedure note.
True.
And then he goes on to say what's done there, and then he indicates that the EKG seems to have been done.
That's correct, and had a significant abnormal finding.
I was going to ask you about that. There's a significant abnormal finding on the EKG.
Correct.
BP's blood pressure
Yes, blood pressure.
remained low, and patient was placed on vasopressor.
Correct. Levophed is a vasopressor.
Then, after all that, she has another episode, she codes again.
True.
Another round of CPR was started, but this round is in the hospital.
That's correct.
And what's CXR?
That's chest x-ray.
Confirmed tube placement, but show pulmonary edema versus ARDS.
Correct.
And then this is continuing to be the ER physician note. Patient remained in very critical condition with poor prognosis.
Yes, that was Dr. Gluckert's assessment.
And right above it, severe acidosis, right?
True.
She's getting the bicarb.
She is.
That doctor's name.
Sure, it is GLUE, G-L-U-E-C-K-E-R-T. And then just going to Ms. Hodge, that history and physical, this appears to, it says up here, dictated by Genevieve Deichel. Do you see that?
That's correct. D-E-K-I-E-L.
And talks about how the Ms. Hodge had a code while she was at home.
Correct. A witness cardiopulmonary arrest.
And why I asked you about the stats for someone that has CPR outside the hospital is because from the medical note, we know that bystanders that were with her when she had the code, they gave her CPR before she was at Mount Carmel.
Yes, they did.
And then she achieved a pulse, and then pressor started. This is at the hospital, and then again she lost the pulse.
True.
Underwent one round of epinephrine with regain of pulse,
Yes, that's accurate.
right? And then she lost the pulse again.
Correct. She had developed atrial fibrillation and low blood pressure, the hypotension, and then lost a pulse again.
And every time she loses a pulse, you would agree with me that in medical terminology, that's considered a code.
Correct. The loss of a pulse is called the code blue situation.
I'm going to go to page 227 of your deposition. Where you are asked questions about how every time someone has a code, you essentially reanimate them to life. Do you remember testifying as to that?
Yes, that's correct. Every time you initiate basic and advanced life support, you are reanimating their perfusion and thus restoring their life capability.
And then it's page 219 of this deposition. One moment, Your Honor. I will find that quote. Thank you. Next page. Two what? Seven, sorry. Just one moment, Your Honor. I will find that in just a second. 1 second. Okay. There was a question you were asked, and maybe it's just easiest to ask you this, in your deposition about every time someone codes, isn't it true that their life expectancy decreases?
That's correct. With each subsequent code, I would counsel the family that it becomes less likely that they will have a good long-term prognosis.
So with respect to Ms. Hodge, multiple codes?
Yes, definitely. She had documented multiple code blue events.
And you would agree with me, multiple codes in a short period of time. This is all one day.
Correct. It was all on one day.
I want to talk a little bit about acidosis. I know it's been something that's talked about, showing you Joint Exhibit 7, page 90. With respect to Mrs. Hodge acidosis level, it's indicated, is it not, as a 6.73?
That is correct. That's what's documented.
And when in the medical field or healthcare profession, with respect to pH levels, there's a high range and a low range, is there not?
That's correct.
And on direct, you were asked questions about this, but fair to say that anything under a 6.8 is considered not sustainable with life.
That's correct. Unless there is a rapidly reversible cause, such as diabetic ketoacidosis, I would agree that it bodes for a very poor prognosis and reflects severe metabolic acidosis.
And we have this measurement on her at 4.1.
Yes, we do.
At 2003.
Correct.
And just as a follow-up, I know you indicated in your report, doctor, that when you talked about my client's notes with respect to Ms. Hodge's extubation, you called it a death note. Do you remember that?
That's correct.
I'm just showing you progress notes with respect to Ms. Hodge. I know that's your characterization of it, doctor, but I want to be clear that death note as a either medical record terminology or as any notation entered by Dr. Husel never appears. The death and note.
In this specific note, no. There were other examples in other patients in which the term death note was included.
And I wrote down that you mentioned it with respect to Ms. Hodge. So while we're here, patient arrived in code. right?
Correct.
Family updated regarding grim prognosis.
True.
And then the note indicates all family members in agreement with DNRCC.
That is what's stated in this note.
And do you see how members is plural?
Yes, the members would imply more than one.
And if you recall from your review of the medical records, Ms. Hodge was fortunate to have quite a large family there with her at bedside, was she not?
Yes, she was.
Moving now to Ms. McDonald. Cancer survivor?
Yes, ma'am. She was a ovarian cancer survivor and had been in remission for 3 years before her return of the cancer.
But then we've subsequently learned from the medical records that the cancer returned, did it not?
That's true. She had come out of her remission and now is battling cancer once again.
And then on top of the ovarian cancer, it had metastasized, it had spread.
Yes, her oncology notes infer that she was receiving this aggressive treatment because of the spread of the cancer.
I want to go with respect to Brandy McDonald is to your note on 31. Again, same note where it appears that Dr. Husel, failed to clearly delineate Ms. McDonald's status was not yet terminal. So, just showing you joint exhibit page 18. This is a consult by Dr. Stoycheff.
Correct. Stoycheff.
And if you recall from your review of the records, which type of doctor is he?
He was a kidney doctor brought in to consult about her renal failure.
Because her kidneys were failing.
Correct.
And this is his consultation note, joint 5, page 2021. It says, does it not, that the patient is critically ill with severe lactate acidosis.
Yes, that was his opinion.
And we just talked about acidosis and what are severe numbers, right?
True.
The possibilities for this include her liver failure versus metformin toxicity.
Correct.
Right now, she is rapidly getting worse, and I am concerned given her pH is now 6.9.
That's true.
And we had just talked about, with respect to the scale that is used by healthcare providers, 6.8 is not sustainable with life.
Correct.
And then he talks about other measures that he would like to do. And further consultation note says, does it not, severe pH, and now she is in danger of cardiac arrest. Lactic acid rapidly increasing.
Yes, he does indicate that sentence.
Then further on, now we have Dr. Klosser. So a second doctor indicates on 115, the patient is critically ill with impairment of one or more vital organ system, such that there is a high probability of imminent or life-threatening deterioration in the patient's condition.
That's correct. That was his notation.
And Dr. Klosser spends, as he notes, 83 minutes with that patient.
True.
And her cancer was such that she was part of this aggressive experimental treatment, was she not?
Yes, she had enrolled voluntarily in an experimental protocol to try to once again bring her ovarian cancer into remission.
And then I want to show you a note, Joint Exhibit 5, page 46 to 47, with respect to Ms. McDonald. Third doctor, would you agree?
That's correct.
And the notes here, patient is critically ill, poor prognosis.
True.
And this is the doctor, Dr. Chand, on 114, that says they began the discussions with the husband, mother, and father. Do you see that note?
I do see that.
They do not want heroic measures should this patient have a cardiac arrest. Do you see that?
Correct, that's true.
But want us to try all other means, including dialysis, if needed.
Yes, that's accurate.
Okay, and then of course, the code status was changed to DNRCCA.
True.
And that note says, but they're willing to try dialysis if it could work.
That's correct.
And dialysis was tried.
Exactly.
Joint Exhibit 5, page 283. Doctor, you would agree with me that because the family said she doesn't want any more, but maybe we just try dialysis, they did.
That's correct. They gave her a trial of CRRT, but it appeared that she clotted off the filter of the machine, so they had to terminate it. They tried to resume it. They stopped it at where she clotted at 2 p.m. They tried to resume it at 2:40, and then by 2:59, her blood pressure went down, so they stopped because with dialysis, you have to pull the blood out of the patient, so her blood pressure down, and they then stopped the attempt.
So they tried twice with dialysis,
Correct.
but her body just couldn't do it.
It did not appear that she could tolerate it at this time.
Your Honor, I can finish up this patient and take a break if you'd like. I only have maybe 1 or 2 more minutes. It's up to you.
Okay.
Just showing the witness.
We're a little ahead of time, but it's probably a good time.
Oh,
to
I'm
break.
not finished with it, but I'll,
Yeah, go ahead and finish up this particular patient. And
thank you. And then, just want to take this off. Just want to show that this is the discharge summary, and this appears to be Dr. Shand, right?
Correct. He was the hospitalist.
And he was the one that we saw that had previously seen her when she first arrived.
Correct.
And just want to go to his note down here that the patient continued to decline, requiring high pressors. So that's vasopressors, right?
That's true.
And was in fulminant hepatic failure.
Correct.
Tell the jurors what that means.
So hepatic failure means that her liver was failing, and fulminant means that it appeared that it was trending towards end stage.
And that's why they tried that dialysis twice.
Yes, that, and because she appeared to have metformin toxicity, which was a medicine she was taking for diabetes, but that can cause acidosis.
And one last thing with respect to Ms. McDonald. She was on 2 different vasopressors, was she not?
That's correct.
And I'm showing you Joint Exhibit 5, 296 to 297. This is her systolic blood pressure.
Correct. That's the upper number, the systolic blood pressure.
And do you see, as of 1/14/2151, do you see what number it is there?
Yes, at 9:51 in the evening, her upper number was 42.
And this was before she was extubated, is that correct?
Correct.
And if you could just generally see the trend, doctor.
She had a downward trend.
And it starts, does it not, at 14:06, it's 116.
Correct. At 2:06 in the afternoon, and then it trended downwards.
And then it's so low that it gets to a 42, and then do you see how it gets to a 40?
That's correct.
Tell the jurors, if you could, what is not sustainable with life with respect to systolic blood pressure?
Usually a sustained systolic blood pressure below 65 would not be consistent with a patient being able to sustain life.
And I just want to show you the back page that on this side, so we have 42, so she's got 42/28. Does that look right, doctor?
Correct. The diastolic blood pressure, the lower number, was at 9:51, was 28.
And what's a normal person's?
A normal person's is between 70 and 85, so this is quite low.
We're at the not sustainable with life phase here, aren't we, doctor?
Correct. If this were to continue, it would certainly pose a threat to her life imminently.
Your Honor, we can break if you would like.
okay, sounds like a good idea. Ladies and gentlemen, 15 minutes. I don't know about you, but I'm warm, so
Yeah.
all right. It's getting a little toasty in this wool. Okay, have a great break, 15 minutes. Doctor, remember the admonition, go have your break, get out of this hot room. Okay. First things first, Ms. Brab, anything for the record?
Not at this time, Your Honor, thank you.
Ms. Menashe.
No, Your Honor, thank you.
Okay, when we were in conference earlier, we talked Did she bring down those other two?
That's all I have on it. They're on their way back up.
Okay. What were they doing? Collecting? Yeah.
Well, I mean, they're probably upstairs.
Ladies and gentlemen, we're going to continue on 1 second. What we're talking about, ladies and gentlemen, I've opened up the doors out there. I'm trying to get a breeze through here, so David's going to be opening this back up. If we have any disruption in the hallway or anything, we're going to be forced to close it down, but I'm trying to do something. I can't find Dan to get an answer why the sauna's in place today, but, okay? Mr. Nash, sorry about that. Doctor, you're still under oath. You may continue.
Thank you, Your Honor. Doctor, I'll turn, if we could, to patient Ms. Schertzinger. Just want to go to your finding with respect to number 16, where you talked about the paralytics that Ms. Schertzinger had been given, and you listed 2 paralytics there. It's now your testimony that actually those were the paralytics that Ms. Penix was given, not Ms. Schertzinger. Is that correct?
That was an incorrect statement. That should be deleted from my report.
And so then I know that you have this next finding about the paralytics and the pain or discomfort. So I want to go over something that you testified to.
Your Honor, I'd like to interpose an objection because the testimony is that he misnamed the paralytics.
No, I'm sorry to cut off, but I'm,
Ms. Schertzinger was on paralytics. It was just a different paralytic.
yes.
So to cross all that out.
I'm sorry, as the jury will see, Your Honor, I certainly did not cross it all out. I just crossed out right to there, the Becheronium, which I think, Doctor, is where you stop with your information that's incorrect. Is that fair to say?
Yes, that's a true statement.
Because inaccurately, you told the jury that she was actually given the paralytic of, I won't even try, Doctor.
It's succinylcholine.
Succinylcholine. And at the break, fair to say that I had approached you with Defendant's Exhibit Hans 22.
That's correct.
And just so that I would give you an opportunity to review, this showing you, does this look familiar as to what you reviewed?
Yes, this is the package insert distributed with the drug for succinylcholine.
And I realize that we've used the term packet insert without a full explanation, but you just gave one. With the drug comes this insert that talks about the purpose of the drug and all things related to the drug.
Correct. It comes from the manufacturer and is published both in the physician's desk reference and is distributed with the medication for available review by the pharmacists, the doctors, and the nurses.
So, and this is why I bring it to your attention. If I could go to the highlighted portion of Defendant's Exhibit Hans 22, right here, Doctor, do you see this adult section that's highlighted?
Yes, I do see that.
And before I ask you about that, as a matter of practice, you testified on direct that when someone is intubated, it's good practice to give them a paralytic so that the tube can be put down their throat. Is that fair to say?
So it is correct. In order to intubate them, it is standard practice to administer paralytics.
And so I want to ask you about this highlighted section in this insert to this paralytic. Indicates, does it not, neurological blockage develops at about 1 minute. Does that look accurate?
Yes, that looks accurate.
So if someone is given this paralytic, within a minute, it can take effect on my neuromuscular system.
Correct. As soon as 1 minute.
Maximum blockage may persist for 2 minutes. Do you see where it says?
Yes, that's true in the average patient.
And then in the average patient, adult patient, after which recovery takes place within 4 to 6 minutes. Do you see that?
I do see that. However, there is certainly a major proviso in critically ill patients and those that have a genetic deficiency, because what goes on later to be described in this package insert is that the drug is actually broken down by pseudocholinesterase. And if you don't inherit the gene from your mother or father, then this drug acts like a long-acting neuromuscular blockade and will create a phase 2 block. Also, when you're critically ill, the liver doesn't make pseudocholinesterase. So again, it would act like a long-term neuromuscular blocker.
Okay, no indication in the record that you reviewed that this patient had this gene that you just talked about. Would you agree with me on that?
I would agree there was no testing done to determine whether or not she had pseudocholinesterase deficiency.
So, and I just go back to the packet insert, takes effect into a minute, maximum 2 minutes, and then recovery means that it peaks, right, 1 to 2, and then 4 to 6 tapers off. Is that a fair way to say that?
That's correct. The block begins to rescind and the patient begins to have some element of movement.
And then showing you the code sheet for this patient. And when I say this patient, I mean Ms. Schertzinger. Does that appear to be a code sheet that belongs to that patient?
It is, yes. This is the code sheet that was included in the medical record.
And if we could see the individual who intubated her, it appears to be Dr. Husel.
It does, yes.
And the time of the intubation is 21:50.
Correct, which is 9:50 in the evening.
So while your report was inaccurate about the named paralytics given, I just want to be clear that Dr. Husel gave Ms. Schertzinger a paralytic when he intubated her.
Yes, that's correct. I don't believe it's listed on the code sheet. I think that was in a separate note.
It is, and I think it was in the MAR. Does that sound like where it might be?
Yeah, it's usually there and in the procedure note.
But you know, and that would make sense, right? Here she's, I'm sorry, it appears right here, it says PT intubated.
Yes, patient intubated PT.
And then she's put on vasopressors.
Correct.
And I want to just go over here so the jury can understand. She's at 21:56. She's got a 70 heart rate. Is that right?
Yes, that's correct.
And then at 21:58, it drops to a 68.
Correct.
And what happens when it drops?
So when the heart rate, here the heart rate, it's only a minor drop, but they did administer the epinephrine because she remained in PEA, as you see in the column next to it, which is pulsus electrical activity.
And that's at 2200, do you see that?
Correct.
And then we have this where it comes, the heart rate comes up to 74, the last note here.
Yes, you're correct. And right next to that, it says ROSC, which is return of spontaneous circulation. Her heart started to squeeze again and pump blood.
And so as a result of this intubation, it went successfully and the life-saving measure worked here.
That's correct.
And just again, so the jury understands, when you talk about in your report the paralytic that was given to Ms. Schertzinger by Dr. Husel, or in the record at all that day, this is the one paralytic that's given with respect to this intubation.
Yes, correct. It should, my report should have read succinylcholine and not Nimbex and Vecuronium.
And then just so we can be clear, if you remember, the intubation time was 21:50.
Correct.
Fair to say that the extubation time was 23:24.
Correct.
And then I just want to go through, if we could, again, you know, the finding that I've highlighted on most every report with respect to the documentation as to the patient not being terminal prior to Dr. Husel seeing the patient, and that things, medical surgical interventions had not been exhausted. Showing you what's been marked as Joint Exhibit 3, page 92 to 94. This appears to be a progress note from, would you agree, it's a cardiologist?
Yes, Dr. Hackett was the cardiologist that saw Ms. Schertzinger on October the 8th.
And she comes in on the 2nd, and the 9th is when she expires.
True.
On the 8th, he indicates, and I say he because Kevin, I presume, but they indicate that the patient goes in and out of atrial fibrillation.
Correct, yes, she did.
And the sodium is improving. Do you see this?
Yes, she was more alert and starting to feel better, and her sodium was improving.
Okay, and then I just turn to the next page, right? And this next page These are the progress notes. Sorry if I just went in order here. But this, I think, is the progress note for 10/7. Would you agree? So this is the day before.
I thought that was the progress note for the 8th, wasn't it? It was the continuation. I think what he's saying there is the weight was from the 7th. It says weight today, the 8th,
yes.
and underneath that, yes. So this was actually his progress note from the 8th of October.
Okay, thank you. And then the assessment is noted as her progress is poor, and so long-term risk of amiodarone is not a concern. What does that mean?
Yes, so amiodarone is a drug that we use for atrial and ventricular tachycardia. It is very effective, but if given for more than a year, it has to be carefully monitored because it can poison the thyroid or the lung. But in his assessment, since he felt that she probably had 6 months to a year to live, that it wouldn't be a long-term problem in using it in her to control the atrial fibrillation.
Okay, doctor, I appreciate that you said that he found that she had 6 months to a year to live.
Well, that's the implication of the amiodarone issue.
And that's certainly, you would agree with me, and you've reviewed these medical records, that no one in Ms. Schertzinger's file indicates that she would have lived for 6 months to a year. I understand that's your testimony.
Well, what I'm saying is the implication from this sentence, because the concern of amiodarone occurs after 1 year, so it would imply that he believed that she would live less than a year.
Okay, so then let's go on, and let's look at the next Joint Exhibit 3, page 531. This is on 10/9, is it not?
Correct.
And this was really my point about showing you the 10/8 note and the 10/9 note, is it's true, is it not, that in an ICU, things change quickly.
Yes, the potential exists for rapid change in the patient's vital signs.
So I take you here to the systolic and the diastolic blood pressure. As of 10/9 of 2235, do you see that it's at a 38/21?
Yes, at 10:35 in the evening, her blood pressure had dropped dramatically within 4 minutes, because just 4 minutes earlier, it was very stable.
So that, just 4 minutes, boom, dropped. And then this is a different doctor. This is Dr. Abraham, who was the attending physician and wrote the discharge summary. Does that sound familiar?
True.
On Ms. Schertzinger?
Correct.
And with respect to the discharge summary, it indicates that she was intubated and transferred to the ICU.
That's correct.
And then we have an HGB of 7.7.
Yes, HGB means hemoglobin, and that was of 7.7 grams,
And that's a 4 GR drop.
a 4-gram drop.
And she was on 3 vasopressors.
True.
Despite all measures, shock did not improve, and the family decided to stop all aggressive resources. Do you see that?
Yes, I do see that.
Then, with respect to, we covered the paralytic. Let's go to Bonnie Austin. I didn't hear, doctor, in any time that you testified about Bonnie Austin, that she had an external pacemaker. Do you remember mentioning that during your direct?
I don't believe that I was asked about that, but yes, I think an external pacemaker was placed because she came in receiving CPR, so they externally paced her.
And as I understand it, external pacemaker, and tell me if I'm wrong, but it's opposed to internal, which we had talked about before, and external kind of zaps you to stimulate the heart? Is that how it works?
One pad is put over where the heart is on the front, and one pad is put on the back. And so electrical stimulation can be conducted through the chest, which would stimulate the heart to beat.
Okay, so I guess in terms of your testimony with respect to Ms. Austin, and this is why I asked it, I remember you saying, quote, there was dynamic variability with her heart rate. Do you remember testifying to that on direct?
Correct.
So I'm showing you Joint Exhibit 10, page 11. This appears to be a code sheet for Ms. Austin, is that correct?
That is correct, yes.
And I'm just curious in terms of the dynamic variability and her heart rate. She has an external pacemaker.
Actually, yes, she had what's called transcutaneous, which means through the skin, and it was set, I mean, she measured at 41, at 8:31. You can see where it says next to Brady, 41, and then they decided to pace her at 70 beats per minute.
And so, I trust you would tell me if I'm wrong, but right here on her own, at 20:31, on 9/30/18, her heart rate's a 41.
Correct.
Surgeon beginning to place the chest tube right up here.
That's right.
She's having a code, and then her heart rate on her own is a 41. And then at 20:47, they began pacing her heart with the external pacemaker, right?
That's true.
You would expect, and you have reviewed the medical records in this case, that once someone has an external pacemaker and they begin pacing, that the pacemaker and the rate that it's set at is thereafter the heart rate.
So the patient can go above that heart rate, but when you pace it at 70, that means you've established the lowest that you allow the patient. It sets the floor to which the patient cannot go lower.
Because if I'm right, if your heart were to be below 70, the pacemaker kicks in.
Correct.
So then, I ask you that because of your testimony about the dynamic variability, and you would agree with me that as indicated by this code sheet, there isn't variability. She had a 41, and then they gave her that external pacemaker.
Yeah, so Mike, when you mention dynamic variability, it means that she was capturing once the electronic pacemaker was turned on, because some patients won't capture, so there was variability between the 41 and the 70.
And this patient was, Miss Austin was on a ventilator.
She was.
I should have asked you this, doctor, but every one of these 14 patients that you are here to testify to today were on a ventilator and were palliatively, there was a terminal vent withdrawal.
That's a true statement.
And so with respect to Bonnie Austin and the general language that I've referred to repeatedly about Austin's status was not yet terminal and further medical and surgical interventions had not been exhausted. I just want to show you Joint Exhibit 10, page 18 to 19. Does that appear to be an ER note from Dr. Gentile?
Yes, Dr. Gentile was the emergency room physician that initially responded to her cardiac arrest when she arrived.
And Dr. Gentile's note under constitutional says, as I've highlighted there, critically ill patient, does it not?
That's correct.
And then the progress note here on 10-1 from the nursing note says patient brought to ICU at 21:47 after losing pulse 5 different times. Do you see that?
Yes, that's a correct statement.
And this is Miss Austin.
It is Miss Austin.
Just series of codes quickly for Miss Austin. Is that fair to say?
That's correct.
And this note is from Nurse Ebrow.
Yes.
And then, so we have the Dr. Gentile, and then we have here Dr. Tom Brady, physical and history and physical. Do you see that, doctor?
I do see that.
And the date on that is, it's one of these resident reviews, is it not?
No, that's actually incorrect. What happened was that the patient was seen by his physician assistant, and then before he could come in to see the patient expired. So then he added an addendum to the PA note.
And so this is the addendum right here?
Correct.
Okay, where she was having agonal respirations and had no oscillated heart tones?
Auscultated.
Okay. And then going on to, this is Dr. Brady's, and at the bottom it says history of present illness. It notes that the family has decided to withdraw care. Do you see that?
Yes, that was actually the entry of PA Alverna Hess-Bow. If you look right above your finger there, she authored that entry.
And so I just want to go quickly, if we can, and not because it doesn't warrant time, but we've got COPD
True.
on Miss Austin.
Yes.
Chronic respiratory failure.
Correct.
And the respiratory failure means which organ?
The lung.
Hypertension, where does hypertension is?
That's high blood pressure.
And then we've got stage 4 chronic kidney disease.
Yes, her kidneys were about to fail.
So we've got lungs, heart, high cholesterol, is that right?
A high blood pressure.
High blood pressure and kidneys,
Correct.
chronic kidney disease. Is that right?
That's correct.
And then a chest tube is put into her, and then you testified on direct the complication that takes place when the groin line is put into her. I'm sorry.
Well, simply, they were unable to get her groin line. There was the other patient, I believe Ms. Schertzinger, who had the hematoma, but Ms. Austin, they just couldn't access.
Oh, I'm sorry. So let's look at that. Yes. So a right groin central line was attempted to be placed, but ultimately was unsuccessful.
Correct.
So they couldn't do that.
They tried, but they couldn't get into the vein to put the catheter in.
And then we've got just this, the history and physical note, joint 10, page 15. This is the note, again, with Ms. Hess-Bugh, B-U-G-H.
I think it's Bow. It was
Bow. That just indicates, and you would agree with me that those words are quoted there when talking about the family indicated that Miss Austin, quote, would not want to live like this, end quote.
Yes, physician assistant Bow did put that statement in quotes.
And then right here, doesn't it say critical care, managing care,
It does, yes.
discussed care, and plan to withdraw care?
That's what PA Bow wrote in her note.
You'd agree with me that nowhere does it say that Dr. Husel initiated that conversation.
Correct. There's no mention of Dr. Husel in PA Bow's entry.
And with respect to Miss Austin, I know she was on vasopressors. She had that external heart rate, or the pacer.
Correct.
And she was on the vent. I just want to go here to her systolic and diastolic blood pressure, 9/30/2018 at 23:30. Where is she there?
There she had a significant drop in the systolic. The diastolic had already been low.
And this is the diastolic column, as you testified, had already been somewhat low, but this is a significant drop, the 109 to a 64, is it not?
Yes, that's a true statement.
And this is while she's still on a vent.
Correct.
Fentanyl peak time. I know we talked about the paralytic, and I kind of did this visual, but fentanyl peaks 5 minutes. Would you agree with me on that?
Yes, the commonly accepted belief is that fentanyl will peak within the body, particularly the brain, within 5 to 10 minutes.
So if I get a push, an IV push of fentanyl, from when the push is done, science seems to support that 5 minutes is its potential peak, and then it starts to come down after that.
Yes, we call that the arm-brain circulation time. So in a patient with normal heart function, from the time I inject it in the arm, it would take at least 5 minutes minimum to have peak effect, and it could be as long as 10. Of course, if the heart is injured, it would take a longer time because it would take longer to pump it to the brain.
So I want to just go to Defendant's Exhibit 10, page 106. And Ms. Austin is a 600 microgram fentanyl order and administration, correct?
Yes, that's correct.
This is the MAR, so this is when the medication was actually given.
Correct. When it reflects when the order was put and then when the actual medication was given by the nurse.
And the time there is 23:22? You see that?
Yes, that's correct.
On 9:30.
True.
And then if we go here, we go to 9:30, 23:30. So this is 8 minutes later.
Correct.
Do you see that?
Yes.
And what's her respiratory rate?
It is 16 down from 26.
She's still breathing at 16 breaths per minute.
That's correct.
8 minutes later.
Correct.
And you would agree with me that Miss Austin had been seen by, in her 5-day stay, I'm sorry, oh actually, even in her short time at Mount Carmel, she had been seen by Dr. Brady, Dr. Gentile, Nurse Ebrow. There was other physicians and nurses that had attended to that patient.
I would respectfully disagree with you. Dr. Brady specifically noted that he was unable to examine the patient while she was alive because the terminal withdrawal had occurred before he could get to the bedside.
And that's a good point you make, because he says here that patient was seen and independently examined by Alvaro Hess
Correct.
Boo. And so I should have asked you, it's true that instead of Dr. Brady, that Alvaro Hess Boo had seen this patient?
Yes, that is correct.
And according to the notes, examined independently.
That's correct. She examined him without Dr. Brady present, or she examined Miss Austin without Dr. Brady being present.
And that note indicates here she was actively dying. Do you see that?
I'm sorry, can you point? Oh, yes, I see that.
We'll go now to Ms. Burke. Same thing with respect to Ms. Burke. I've actually highlighted a couple indications here. Number 6, at no time during the 113 hospitalization was her condition determined to be terminal.
Correct.
And that respiratory interventions had not been determined to be futile. And then going back down here, you indicate that there were further medical and surgical interventions that could have or should have been done for Ms. Burke. Is that, and this is your report as to Ms. Burke, correct?
It is, yes, ma'am.
And then you go on to do that, to iterate what you iterate in every report, which is it appears he failed to delineate that her status was not yet terminal, and other things could have been done. Okay. Want to just go through Joint Exhibit 6, page 10 through 13. This is Dr. Klosser again, is it not?
That is correct.
And this patient was a 73-year-old female.
She was, yes.
I've highlighted here, if you see, that Dr. Klosser indicated there was a mass effect with evidence of early herniation. Neurosurgery was consulted and notified by the ER doc. Do you see that?
I do see that.
The ER doc spoke to Dr. Monkaman, directly felt there was no indication for surgical intervention. Do you see that?
I do see that.
The patient became hypertensive and was started on propofol.
True.
Okay. So then we go to the next page. 73-year-old with devastating ICH while on Xarelto. What's ICH, doctor?
That stands for intracranial hemorrhage, blood in the head.
So Miss Burke has a brain bleed, does she not?
That's right. She was on blood thinners, and she developed a brain bleed from that.
She has evidence of increased intracranial pressure and is herniating. The bleed will be fatal even with the most aggressive care. Do you see that consultation note from Dr. Klosser?
I do, and just above where you have, they made mention on the CT, early uncal and transdental herniation. Those, of course, are herniations that are not necessarily fatal.
Can you start that over?
I'm sorry.
And slow down just a little bit.
Certainly. I apologize. What I was saying was that the entry there was above it, early uncal and transdental herniation changes noted, and I was just making reference that those are not necessarily fatal.
But she has a lot of brain bleeding going on, doesn't she, doctor?
She did have significant brain bleeding, and there was significant swelling in the left side of her brain.
And that swelling creates incredible pressure, doesn't it?
Correct. In the adult, the skull is fixed, so it can't swell outward. So this is consistent with concerns about the pressure that Dr. Klosser mentioned.
And when I'm bleeding out like that, if I have a brain bleed, can you vasopressors? Can you give me vasopressors?
Yes, if the bleed is consistent with the blood thinner, by reversing the blood thinners, you can then support cerebral perfusion pressure with titrating vasopressors.
So let's go on to the next note. Again, this is Dr. Klosser. The patient is critically ill with impairment of one or more vital organ. So now it's not just the brain though, right, doctor?
Correct, because at that point now she was intubated, so the lung is now also impaired because she's on the ventilator.
So now we have two different organs at issue here,
Correct.
right? Critically ill, such that there is a high probability of imminent or life-threatening deterioration in the patient's condition. And then Dr. Klosser indicates that 33 minutes of critical care time were spent independent of procedures. Do you see that word procedures?
That's correct.
Full vent support. Do you see that?
I do see that.
And again, we talked earlier about when someone is on full vent support and there is a terminal ventilator withdrawal, 4 to 5 minutes is what you testified to in your deposition.
That's correct.
And then these comments, this is the progress note. Dr. Klosser again. I showed them the image of the CT head and explained the findings. Do you see that?
Yes, I do see that.
Okay. So that's not Dr. Husel.
That is not Dr. Husel.
And then Dr. Klosser explains he went on to very small chance if she were to survive, the potential of complete neurological recovery is essentially, and what word does he put there?
He puts nil, which means that it would be essentially to return to her baseline would be 0, that she has a small chance of survival, but she would have a significant deficit.
I emphasize to them the massiveness of the stroke will ultimately lead to brainstem herniation, which will cause her to go into cardiac arrest, leading to further neurological damage. Do you see that note?
I do see that note.
And that note is again by Dr. Klosser, correct?
Yes, correct, which I think served as the premise for him to make her DNR-CCA.
And so then you know from your review of the records that he's the one that initiated that conversation.
That's a true statement.
And then I just show you Joint Exhibit 6, page 21. This appears to be Dr. Poulantinas. Do you see that?
Correct.
And with respect to this, I show you this because of your finding or your conclusion that there was other measures that could have been done for Ms. Burke. I wanted to make sure that you saw this note from Dr. Poulantinas. Down here, X-ray shows the tube, and then it goes on, does it not? And the highlighted line says, I spoke to neurological consultation who states there are no interventions for this particular bleed on this particular agent. Do you see that?
Yeah, what this note refers to is that she was not a candidate to open the skull and go into the brain because the bleed was in the brain itself, so it would have caused more damage with her having been on the blood thinners. So she wasn't saying you couldn't do anything, just in terms of actual neurosurgery, she would not have been a candidate.
Couldn't drain the bleed, right?
That's correct.
That was a surgical measure that was not available to Ms. Burke.
That's what this note infers.
And then, again, a second doctor, in addition to Dr. Klosser, Dr. Poulantinas, counseled the family that this bleeding is life-threatening and there is a very grim prognosis.
Yes, that's true.
And then ICU is aware, CIC is aware. Who's CIC?
Well, it says the patient will be admitted to the ICU, comma, and then CIC stands for Columbus Internal, I forget what the third term, but it's basically the hospitalist group that's here in Columbus that staffed Mount Carmel West.
And I asked you that because that's the Columbus Inpatient Care, isn't it?
Correct, Columbus Inpatient Care, which is the hospitalist group.
And they staffed and were the attending physicians for a number of these doctors.
They were, yes.
Then I go to Frances Burke, Joint Exhibit 6, page 121. I just want to show you, it's a 2 pages I'd like to show you. This right here at 113/1916, her systolic and diastolic BP, 231/59. Do you see that?
I do see that.
And that's 1916.
Correct, 7:16 p.m.
Oops. Where's my page 2? Oh, here it is. Sorry. Notified Dr. Husel that the blood pressure was 68/43. and that time is 23:03.
Yes, that's 11:03 p.m.
So 4 hours later, the systolic, the blood pressure's gone from 231/59 to 68/43.
Correct, because with the initiation and the brain bleed, she developed a high blood pressure to try to pump more blood to the brain, to try to salvage the brain. And then there was a recommendation for nicardipine, which lowers blood pressure because obviously you don't want continued bleeding. And then she did swing the other way and develop low blood pressure.
That kind of drop, you would agree, shows the sign that the brain is significantly hemorrhaging.
It may show that. Usually it will tamponade itself off because of what we discussed earlier, but it certainly shows that there's more swelling in the brain.
Okay, well, let's talk about this. Do you see that this decline right here?
Yes, correct, because they were concerned about the hypertensive response, so the therapeutic approach would be to try to lower the blood pressure to avoid further pressure on the area of the bleeding.
And this note indicates that Dr. Husel was notified.
And right where the arrow is, it specifically says Cardine GTT and Propofol GTT, which were the medicines used to lower the blood pressure. They had turned off because the pressure dropped.
And then I just want to make sure that we're clear here that Dr. Husel, at this point in time, according to the nurse's notes, bless you, wanted to continue to monitor, right?
That's correct.
Let's talk about Troy Allison. Troy Allison, for cardiac arrest.
Correct.
And I know we talked about earlier, but every time someone has a code, so that's true for any person, it shortens their life expectancy, does it not?
Statistically, if you look at it with each code, it reduces the chance that they're going to survive.
So Troy Allison, just again, just the 30, the finding that you make there about Mr. Allison's status was not yet terminal and interventions had not been exhausted. Just want to go to Joint Exhibit 9, page 18 to 20. This is a physician note from Dr. Woodard. Do you see that?
I do see that. He was one of the ER physicians at Mount Carmel West.
And this long history that Dr. Woodard dictated, and I know the jury's been seen this a number of times, but you would agree, doctor, that this details the codes that Mr. Allison experienced.
That's correct.
It talks about stop breathing and then pulse regain and then CPR had to be administered, et cetera, et cetera.
Yes, and it also indicates that Dr. Woodard was the physician who put the breathing tube into Mr. Timmons.
And here where it's highlighted, his pH is a 6.5.
Correct.
And then,
With a blood sugar of 875.
yes, and I think I was going to get to that. I think it's somewhere in the record. Doesn't it even say it gets to 899?
Correct.
And actually, that's right down here, doctor. Do you see that?
I do.
My finger is. So it's at 899. That's what's normal. So the jury.
Normal is 70 to 110.
And then this is Dr. Woodard's note. The patient was eventually transferred to the unit, but the patient was in severe critical condition. Do you see that note?
I do, yes.
And then we've got this presumed, in terms of consent, right? Life-threatening condition, presumed
correct.
due to emergent life-threatening condition. And then here we've got this class 4 marked, incapacitating systemic disease.
Correct, but Dr. Woodard did not check class 5, which means the patient's terminal, so he still held out hope that the patient could survive.
Sure, so let's go on now, because that's Dr. Woodard. Let's go to Dr. Patel. Patient discussed with resident. Patient with complicated history presented to hospital as a cardiac arrest. Do you see Dr. Patel's note, poor prognosis? Do you see that? And then it goes on.
I do see that, but then he goes on to say that he didn't see the patient because the patient had already been withdrawn upon. So it's kind of inconsistent that he could opine about the prognosis when he hadn't actually physically laid eyes on the patient.
Okay, I'm not quite there yet. This is his discharge summary. You would agree?
I would agree.
Okay. And you talked about how the attending physician, the importance of the discharge summary. You talked about that in your direct examination, right?
True.
Okay. That's why I wanted to go over the discharge summary. And just that it note, patient died prior to being seen as per family's request to withdraw care. You see that Dr. Patel indicates that note there.
I do, yes. Dr. Patel added that to Dr. Gandhi's note.
And then I wanted to make sure that, just to verify the pH with respect to Mr. Allison, it is in fact 6.533. Do you see that?
It is, yes. On July 14th, and it indicates to the right there the time that it was collected at 11:35. It was in fact 6.533.
And 6.8 is that measure of not sustainable.
Correct, unless there was immediate action to reverse that.
And I know we've just talked about conversations and your testimony about was it premature for Dr. Husel to have conversations with families. We now know after your testimony on direct and your cross-examination that it's fair to say that a number of people other than Dr. Husel actually had withdrawal conversations with these family members.
That's a true statement.
And sometimes in addition to other doctors, whether it's Dr. Moody or Dr. Ralston, that there's also spiritual care notes about conversations that spiritual care providers had with the family as well, correct?
I did see entries by spiritual care or chaplain services about discussions.
And I just want to show you the note on Troy Allison. Does this, the spiritual care note, does this look like a note that you would have reviewed during the course of your work in this case?
Yes, I am familiar with this note. It was written by Cassandra Wilson.
And this note in particular, it indicates with respect to the family time, 150 minutes.
That's correct.
And here, patient's condition did not stabilize. Do you see where it says team informed the family that patient could not survive?
Yes, I do see that in Ms. Wilson's note. But again, she had a major mistake above that, which is I was finally stable enough to receive a CAT scan. Obviously, Ms. Wilson didn't get a CAT scan. She was talking about Mr. Allison.
No, but I think Ms. Wilson would agree with you that she clearly meant to put
Yes.
Mr. Allison, right?
Correct.
Was not stable enough to have a CAT scan, and we know that that's accurate from the records.
I would agree.
And then was moved, and then he didn't stabilize, and then she goes on to say family opted to withdraw the vent support, knowing the patient did not wish to be on life support. Do you see that spiritual care note?
I do see that spiritual care note.
And in each and every patient's medical files was the spiritual care notes if they were applicable, or if there was a spiritual care person there, right?
That's correct. If one was present, they would counsel and provide grief support for the family.
Circling back, at the break, doctor, did I have an opportunity to show you the MARS from patient Timmons?
You did, yes.
And just to refresh the jury, there was a statement in your findings that Dr. Husel had given Mr. Timmons Haldol that would have been inappropriate. Do you remember that being in your report?
I do remember that in the report.
And did you have an opportunity to review Mr. Timmons' medication administration record?
I did, yes. I looked in the break through there, and there was no indication of the Haldol, so that should be deleted from my report.
I want to go to Ms. Penix. This is in your report, page 14. I just want to make sure that we clarify this, because this indicates here Dr. Husel also ordered Haldol, right?
Correct.
And would serve to deeply sedate the patient. Do you see how you, and then you actually even put page 308.
Correct.
Okay. Showing you what's been marked as Joint Exhibit 14, page 308. Do you see this order for Melissa Penix?
Yes, I see the order.
Okay. And so actually, isn't it true that the Haldol was ordered on the day shift? And it was actually Dr. Husel that discontinued the Haldol.
That is correct, yes. What was confusing was when you look on the fourth line, it says ordering physician Dr. Husel, and then the administration, but if you look deeper, then it talks about the discontinuation.
And doctor, you can imagine why, or can you, why I would ask about the Haldols, because you include it in your report as something that would further sedate a patient. And here we are talking about palliative, right, Fentanyl drugs, right?
That's correct.
But so now we know, in the Timmons case, you were incorrect that he gave Haldol.
That's correct.
And now we also know that you were incorrect that he gave Ms. Penix Haldol.
Correct. It appears that the Haldol order actually was placed on the day shift.
And he stopped it.
That's correct.
With respect to Ms. Penix, were you given any information about the home medication that she had taken from 2007 to 2017?
No, I have not seen her outpatient medical records.
So I want to go with respect, and the state only gave you her records from her last admission?
That's correct. I believe I only saw the last admission to Mount Carmel West.
And is that true of all 14 patients?
No, for the Bonnie Austin case and the Millette case, I was provided additional records by civil counsel, but not by the state.
But you know from Ms. Penix's file review that prior to her last admission to Mount Carmel West, that she had received significant amount of medical care.
Yes, that's correct.
So again, I highlight here that her status was not yet terminal and further medical or surgical interventions had not been exhausted.
Yes, that's the statement I put in the report.
So on this, I'm just going to show you Joint Exhibit 14. We've got, in terms of medical things that could have been done for Ms. Penix, she had a CT chest. Is that right, the exam?
That's correct. She had a CT of the chest without injection of IV contrast.
And the results of that was that she had multifocal pneumonia involving all lobes of both lungs.
Correct.
So she had pneumonia in both lungs.
That's a true statement.
And it was worse in the right.
Correct.
With effusions. What does that mean?
Effusion means that there was fluid between the lung and the chest wall itself developing in that area that usually in a healthy patient would only have a small amount of lubrication.
And this is on the 16th, and she passed away 4 days later on the 20th, right?
True.
On the 18th, showing you Joint Exhibit 14, page 681, do you see this note right here about 11:18, worsening dyspnea and desaturation into 80s? She's placed on a BiPAP. I'm not sure we've seen BiPAP before, but doctor, that's where I would have a mask on for my oxygen?
Correct. BiPAP is non-invasive, so you get a face mask, almost like the jet fighter pilots wear, with a strap around the head, and then it increases the pressure to drive the oxygen into the lung.
And we know at this point in time that she has pneumonia in both of those lungs.
Yes, that had already been diagnosed.
Right, and so,
That had already been diagnosed.
and then I've highlighted here, patient desats to 50s quickly when removed. So if she takes the mask off, her breaths per minute drops to 50, is that right?
No, it's not referring to the breast. It refers to the amount of saturation in the blood on the pulse oximeter of the finger.
Okay, so then I guess still the same though. She takes the mask off that's providing her with oxygen, right?
Yeah, if she takes the mask off, the amount of oxygen in her blood drops.
It drops. So then let's go to this note. This is by her attending physician. Dr. Wadicki, does that name look familiar with you?
Yes, Dr. Wojtka was one of the hospitalists that admitted this patient.
Okay, and showing you Joint Exhibit 14, page 73 to 74. And this is the second doctor that's seen her, or no, I'm sorry, this doctor right up here is also noted. But
Dr. Battini.
yes. So I'm just going to go here, 7:20, right? So 2 days later, after that last note we saw about the BiPAP, cannot eat because she desaturates quickly. So you would agree with me, doctor, at that point, she can't take the mask off because it so quickly impacts her. She can't even take it off to eat.
Yes, that is correct.
And then on that same day, she gets intubated on 11.
Yes, because she didn't respond to the adjustable positive pressure or the BiPAP, it was decided that she would need to be intubated and ventilated until the antibiotics could bring the pneumonia under control.
And so that was my next question, is that then she gets intubated, does she not?
Exactly.
And I'll show. Showing you a progress note from Dr. Klosser. And again, do you recall, Dr. Klosser's in the ICU, correct?
Yes, Dr. Klosser was a pulmonologist that worked at Mount Carmel and also worked in the intensive care unit.
So this is 11:20, the same day that she's intubated, right?
Correct.
And you would agree with me that he says this is an addendum to the resident note. So he independently sees this patient.
Correct.
Acute respiratory failure. Ventilator support with Airvo. Do you see that?
That's correct.
Likely going to be needed to intubate. And this is again 11:20. Do you see that?
Yes, I see that.
And then he indicates, he being Dr. Klosser, looks rough this evening and fire 2 requirements are up.
Correct.
I didn't remember you mentioning on direct, but in addition to the pneumonia, she had MRSA, right?
Yes, specifically, not that she had it in addition, but MRSA was causing the pneumonia and needing the antibiotic.
And, I mean, MRSA can be, on its own, a fairly serious condition, can it not?
Yes, if MRSA is in the lung, that requires prolonged antibiotics to destroy and kill the MRSA.
And then she also has a COPD exacerbation noted there.
That's correct.
Your Honor, do you want me to take a break or no?
I just soon drive on. What do you guys think? You okay? Anybody need a break? I'll drive on.
One moment.
I don't know if that door helped, but it seems to.
I opened up the courtrooms.
Okay.
Do you remember on direct, you talked about the order of the Nimbics with respect to Ms. Penix?
Correct.
Showing you what's been marked as Joint Exhibit 14, page 323. I just wanted to be clear about what the records actually indicate with respect to the order for the Nimbics. Fair to say that the order is actually entered by Dr. Husel on 2107. Do you see that?
I see that, yes.
And it actually was ordered by Dr. Husel as an infusion, or I'm sorry, as an infusion, wasn't it?
Correct.
And then actually, the pharmacist, Greg White, and we know pharmacists based on this right here, right?
That's true.
Modified the order, right?
Correct.
Modified and said, not an infusion, it should be a bolus.
That's correct.
And the difference with an infusion, it would have been titrated over time,
Correct.
and a bolus is like a push.
That's right, it is a push.
So based on your experience and training, this is an example of what can happen in a hospital when a doctor puts in an order, and then it's reviewed by a pharmacist, right?
Correct.
And then the pharmacist, presumably based on their experience and training, modifies an order
That's correct.
and then changes it.
True.
And I know we kind of began with some questions about Ms. Penix, so I certainly won't re-ask those, but I do just want to make sure that we understand in terms of her comprehensive issues, is that it wasn't just the pneumonia in her lungs, correct? She also had acute kidney injury, did she not?
Yes, she had abnormal kidney function.
And then with respect to her pH, she had a pH of 6.97.
Yes, that's my recollection.
And if you recall, and lactate isn't something we've talked much about, but her lactate was at an 8, wasn't it?
That's correct, it was elevated.
And what is on a lactate scale, what is not life-sustaining and normal? First, what's not sustainable for life?
So a lactate above 20 is not, if it's sustained, is not consistent with life. Whereas normal lactate is usually 1 to 2. With exercise, it may go up. We worry about sepsis if lactate's greater than 4. When lactate is 8 or greater, it needs aggressive critical care intervention. And as I said, once it gets consistently above 20, that's usually a sign that it's inconsistent with life.
And she had a lactate of 8.
That's correct. It was significant. It needed to be addressed.
And then she also had those aortic valve issues, did she not? She had the stenosis of her valve?
Correct. She had valvular pathology within the heart itself.
And do I recall that she wasn't healthy enough to have that valve replaced?
Correct. Because there was suspicion of MRSA, you couldn't change the valve until you eradicated the infection, because if we were to put a new valve in a patient that has MRSA, the MRSA would attach to the valve and destroy it. So she was not in a position on this hospitalization that a valve replacement could be undertaken.
And we need a valve is critical to the heart functioning correctly.
Yes, you need adequate valve function in order to pump the blood through it.
Now, lastly, I'm going to turn to, that was just, the jurors will not like me when I said lastly, but I have 2 more. I say with a smile. James Allen. This note, actually, I highlight because 13, you indicate despite the multiple code blue events, there was no evidence to suggest that his cardiopulmonary function had progressed to terminal. That's number 13 on your findings. And then with respect to Mr. Allen, you make that same note that you make with respect to all the other patients.
Correct.
So I just want to go, Dr. Mahoney, showing you Joint Exhibit 8, page 3. Here, unfortunately, Mr. Allen, was critically ill with severe systolic heart failure prior to this. He
Yes,
is on maximal support, and we have explained to his family are doing really can for him. Unfortunately, I'm afraid he will not survive this episode. Do you see that?
I do see that.
And just so, Dr. Mahoney is in what part of the hospital, if you know?
Dr. Mahoney is a critical care doctor. Of course, this note itself, you can see, was written by Dr. Gandhi, the resident.
So we've got another situation where a resident writes it, and then it looks as if it's reviewed by someone else, or by the
attending.
The attending. Does that look fair, doctor?
That is fair.
And then it goes on, patient is critically ill with dysfunction of one or more organ systems.
True.
Specifically, he is in acute hypoxic respiratory failure and requires mechanical ventilation. Without this, he would suffer life-threatening decompensation. Do you see that? And then the chief complaint is septic shock.
That's correct, I do see that.
And then a second doctor, with respect to James Allen, I'm showing you Joint Exhibit 8, page 17 to 19. We know Dr. Ralston is an ICU physician, is that correct?
He is, yes.
And Dr. Ralston's on 5/25, and do you see that the patient passed away on 5/28?
I do see that.
I just want to make sure that we go to Dr. Ralston, so different doctor, plan. I did discuss with his son outside the room. I'm very concerned about his limited reserve, given his multiple medical issues and limited pulmonary performance. Do you see that?
I see that.
I did talk with his son that if it becomes a hopeless situation, then it would be my burden to come talk to him as well. You see that?
I do see that, yes.
Because, Doctor, fair to say that having a conversation with a loved one or family member, in your experience, is never pleasant. Having a conversation that your loved one might not know.
I would agree. We always take that extremely seriously because we know in that patient and that family's life, this is really a major event in the progression of the treatment plan.
And would you agree with me that delivering that news is probably never easy?
Correct. It's always a somber event.
And when you're at a hospital, particularly in a setting where that kind of conversation is taking place, wouldn't you agree that that's just a stressful situation?
Yes, it always is a stressful situation.
And so he says in his note that if he had to have the conversation, it would be his burden.
Correct. He is indicating that if the situation eventually becomes hopeless, that he would accept the burden to go back and talk to the son.
And so then I just note that with respect to Mr. Allen, we had the lungs and the heart in terms of the organ system failure.
That is correct. He had both heart and lung failure.
And then showing you with respect to Mr. Allen, Joint Exhibit 8, 528 is 1616. The 90 and the 12, tell the jurors what is the significance of those numbers?
So if you look above, it says capital F, little I, capital O2. That's the amount of oxygen coming into the lung. And 100 means 100% oxygen, which is the highest it can get. And then the second entry at 416 is down to 90%.
And so, sorry, no.
No, I was going to, and then where you see capital P, capital E, capital E, capital P, that stands for positive end expiratory pressure. And that's the amount of pressure when a patient exhales that the machine will put on the lungs, almost as if when you blow up a balloon and you pinch the end of the balloon, you keep the balloon partially distended so the next time you try to blow it up, it's easier to inflate it. That's what the ventilator does to try to make it easier with each breath for the patient to breathe.
And so you'd agree with me that this means it's 100% right here?
Yes, 100.00 is 100%.
100% vent dependent.
No, that's not the same thing. What it means is that he required 100% oxygen. Vent dependence has to do with the proportional amount of how many breaths he has to take versus the machine.
Okay, so then the 100 and the 90 that I have highlighted, what's the significance of the number 90?
90 means that they were beginning to work down the amount of oxygen from the highest amount, 100, down to 90, bleeding with 10% atmospheric air.
So then, that's his direct charting flow sheet. And then I just want to go to Joint Exhibit 8, page 248. Because there's been a lot of discussions about the premature nature of the conversations about comfort care. And as we know from reviewing these records, that actually Dr. Ralston, I believe, had started the conversation with the son, letting the son know the critical nature of Mr. Allen. Would you agree with me on that?
Yes, I would agree that in that note from several days before, Dr. Ralston had begun the process to talk about if things got worse, what might happen.
And then we've got this, from a nurse, this progress note that indicates that the family proceeded to call me to the bedside voicing concerns for withdrawal of care. Do you see that note?
I do see.
And the note indicates that Dr. Husel was then called.
Correct.
And I bring this note to your attention because this note is an illustration, is it not, that sometimes when the family members are gathered and have been in the ICU for days, that they approach the medical staff and say, it's time.
That can happen, yes.
And the note indicates that that seems to have been what happened in Mr. Allen's case.
According to Nurse Deemer, he indicates that he initiated the phone call to Dr. Husel to bring Dr. Husel to the bedside to talk to the family.
I'm sorry, and I just want to make sure that the call to Dr. Husel follows the family proceeded to call me, the nurse, to bedside voicing concerns.
Yes, that's what's indicated in the note.
And then lastly, Ms. Walls. This is one thing that I want to ask you about. You talked a lot in your reports and on your direct examination about this critical care management of at least 72 to 96 hours.
Correct.
You would agree with me that there are a significant number of patients in this case that were in the hospital in Mount Carmel West for more than 72 or 96 hours.
Yes, I would agree with that statement.
In fact, Rebecca Walls was there from 11:13 to 11:19.
That's correct.
And the only shifts that Dr. Husel worked were the nighttime shift at the ICU.
True.
And do you know he didn't work 7 days a week?
That's correct. I wouldn't, again, I didn't see his work schedule, but again, some ICUs do have that. My ICU, we work 7 days a week. Others do not, so it's variable.
And I just want to go to what your findings with respect to Ms. Walls, which it's that similar paragraph I talked about in the other patients, that there were other things, medical or surgical procedures that could have been done for her, and that there wasn't a consensus as to her terminal condition. We've got Joint Exhibit 13, page 83. Again, this is a Dr. Klosser note, is it not?
It is, yes, on the 18th.
Worse again today, acute respiratory failure.
Correct.
And then, if I could, this is a continuation of Dr. Klosser's note, Joint Exhibit 13, page 85. Do you see where it says consult palliative care?
Yes, Dr. Klosser included that in his note.
Poor prognosis?
He did state that.
Okay, she has severe valve disease and too ill to fix it.
Correct.
So when we talk about procedures or medical interventions, she has valve disease, but they can't fix her valve because she's just too sick.
At that moment in time, she couldn't be taken for the TAVR valve. She would have had to stabilize from the underlying processes prior to taking her to the interventional lab for a TAVR.
And then Dr. Klosser, not Dr. Husel, writes that note, I don't think she's going to survive.
That was his opinion on that day, on the 18th.
And then we go on to critical ill, but certainly he writes right in there as a freestanding sentence that he doesn't think she's going to survive. Does he not?
You're referring to the second sentence? Or?
I don't think she's going to survive.
Yes, in what you underlined, I do see that.
Okay. Then there's a high probability of imminent or life-threatening deterioration. Do you see that?
Correct.
And this is for Rebecca Walls.
It was.
And then in addition to Dr. Klosser, she was seen by a nephrologist, was she not?
She was, yes, because she did have underlying kidney dysfunction.
So we've got here Dr. O'Reilly seeing her,
Yes, he was an attending at Mount Carmel West from the kidney service.
and his notes indicated here worsening dyspnea
Correct, which means worsening shortness of breath.
and found to have severe aortic valve disease for which the TAVR is considered, right?
Correct.
And then we know that the TAVR was not able to be pursued.
Yes, at that point, they could not proceed with the TAVR, even though the workup had begun.
And so this second doctor is Dr. O'Reilly. He writes, does he not? She remains vent pressor dependent on levo, so on up to 34 vasos 0.04. So fair to say for her biometrics, she's maxed out on vasopressors.
Well, yes, as far as the amount of levofed or vasopressin you could give, these would be relative maximal doses. If you had to add, you'd have to go to a third or a fourth to supplement that.
And now increasing lactate, and he writes ominous sign.
Correct. Since the lactate was trending upwards, that would be seen as a poor sign. One would need to change the course of the treatment.
And then, because there's, again, just been this issue, and that was two separate doctors other than Dr. Husel.
Yes, that's correct.
Joint Exhibit 13, page 935. We have a note here, do we not, that the nurse spoke with the medical POA, power of attorney?
Correct. POA does stand for the power of attorney.
And in this nursing note, it's quoted, is it not, Rebecca told me that she never wanted to be on machines or resuscitated, end quote. Do you see that?
Yes, Nurse Blair, who authored this note, was apparently quoting the power of attorney as to what Rebecca had discussed with her prior to an admission.
And doctor, you know, do you not, just through your experience, that there are people, I won't put a number to it, that before they get sick, they articulate to those that they love, I don't want to ever be on a ventilator.
Yes, that is true. You do have patients come to the hospital who have had that discussion with either family or with powers of attorney, so that, particularly in the elderly, that others know what their wishes are.
And there is also documents, a living will, for instance, that an individual that feels that way could execute so that the document would speak for them. Let's say the ambulance was called to their house and they were unresponsive.
Yes, it is always wise to put one's wishes into a legal format so that that can be brought to an emergency room hospital. So you not only have to go by what the family or power of attorney has to say, but you actually have written documentation. That's not always available, but it is certainly a recommended option.
And then I just want to go back to this note that Dr. Husel and the chaplain were notified. It seems as if the nurse did that notification.
Yes, the way this entry reads is that Nurse Blair then notified Dr. Husel and concomitantly or at the same time notified the chaplain.
I know the issue of tolerance has been discussed, and so I just want to talk about Rebecca Walls with respect to, does this look like a MAR for her?
It is, yes. This is part of the continuous infusion section of her MARS.
And the date of which she passes is the 19th.
It was, yes.
And this looks to be, this MAR begins, just as an example, on the 16th. Does that seem fair, doctor?
It does seem fair.
So you would agree with me that on 11/16th, she begins to get infusions of fentanyl.
That is correct.
And this right here is an order for Dr. Hagris?
Correct.
And then the 100 micrograms per hour is Dr. Hagris?
That is correct. Dr. Saad Hegris was the one who entered the order for the increase in the dose.
And again, we know that if it's 100 micrograms per hour and it's 8 hours before that order is modified, that would be 800 micrograms of fentanyl that I would have received.
Yes, if it were infused over that period of 8 hours, 100 times 8 would be the total amount, 800.
And so we have here 617. It looks as if at 1101 it was increased to 150 micrograms per hour.
Yes, that's correct. It looks like the action order was at 1101.
I'm sorry, 1101, yes. And then here at 1133, it's modified to 100 micrograms per hour on the 17th, so the next day?
So essentially, the next day, it's been brought back down to 100 mics per hour.
And then on the 1118,
It stopped.
it's stopped altogether.
Correct.
Right? And we know that the date she passes is 1119.
That's correct.
Your Honor, I have about 15 more minutes. Like me just to keep going?
I'm here all day.
Okay, all right. Me too. I just want to kind of circle back now and talk more globally about the 14 patients, if we can. Well, let's just talk about the pH, and we'll just go through them, each patient quickly, and I won't restate the chart because we know the levels. But we've got Troy Allison, Defendant's Exhibit 9, page 70, 6.533.
I see that.
Jeremiah Hodge, Defendant's Exhibit 7, page 90, 6.73.
Correct.
Defendant's Exhibit 5, page 243. Brandy McDonald, 6.932.
That's true.
James Timmons, Defendant's Exhibit 11, page 324, 6.95.
I see that.
Beverly Schertzinger, Defendant's Exhibit 3, page 390, 6.96. Would you agree with me, Doctor?
That's correct.
And then Danny Millette, Defendant's Exhibit 4, page 191, 696.
That's true.
And then Ms. Penix, Defendant's Exhibit 14, page 357, 697.
Yes, I see that.
And then I have all the code sheets marked, but I will, in the interest of time, because we haven't just hit on the codes with respect, but Danny Millette, Doctor, would you agree, whether it's 3 or 6 codes, it's somewhere in between 3 to 6 codes?
Yes, he had 3 major codes, some of which there was a break and then return. So you could, depending on how one would count it, he could have had as many as 6.
And then Bonnie Austin had 5 codes?
Correct.
Troy Allison had 4 codes.
True.
Jeremiah Hodge had 4 codes.
That's correct.
James Timmons had 3 codes.
That is my recollection.
Sandra Castle, 2.
True.
Ryan Hayes, James Allen, and Beverly Schertzinger had 1 code.
Correct.
And then, with the issue of those that were on full life support. So those that had both mechanical ventilation and vasopressors. Instead of reading the list of the 12 patients, you would agree with me that 12 of the 14 were both on the vent and had vasopressors.
Yes, that's correct, that they had what would be described as cardiopulmonary resuscitation with both ventilator and vasopressor infusions.
Now, Francis Burke was on the ventilator but did not have vasopressors.
True.
And that's why I asked you, that is again just to remember, and I don't mean this out of disrespect, but she's the woman with the brain bleed.
Correct.
There was a note in the file, though, was there not, that because of the hemorrhaging in the brain, the decision was made not to put her on vasopressors? Do you remember that?
I do.
So she had the brain, and for fear they could make the brain worse, she was not put on vasopressor.
That's correct.
And we had Sandra Castle was on the mechanical ventilator, but not on vasopressors.
True.
And she's one of our day shift extubations.
That's correct.
I noticed, and I understand the focus of your work in this case, Doctor, but I noticed that in your report, just generally, didn't list all the things that Dr. Husel did that helped save these patients' lives before the decision was made for the terminal vent withdrawal. Would you agree with me that your report didn't include those things?
I would agree that that was not the focus of my report to include every intervention, but I would acknowledge that certainly on at least a few of the patients, Dr. Husel had intubated the patients or provided other services such as line insertion and orders for the patients. So I'm not minimizing that involvement in their care.
And I remember, and tell me if you do, but like in the Belisari case, Albert Belisari actually walked to the nursing station to advise of the family's decision to withdraw care. And just an hour prior, Dr. Husel had been ordering IV bags. Do you remember that?
That is,
How would this witness know what Mr. Belisari did?
My question, sir.
Okay. Do you have, from review of medical records, did you see anything in there about Mr. Belisari?
I did not see anything, nor did I get a deposition regarding Mr. Belisari.
Okay.
Let
You
me-
want to rephrase your question
Sure.
then?
Let me get to the note. Well then let me just ask you this. You know at the time of which Ms. Belisari was extubated, correct?
That's correct.
And you know from the review of the medical administration record then that approximately an hour before she was extubated, Dr. Husel was ordering things that were medications that were helpful to her.
I'd have to look at the MARS to see the specific orders, but there were orders placed prior to that period of time. Prior to that time.
I know that you were asked in your deposition, and you certainly talked on your direct examination about the doctrine of double effect.
That's correct.
You mentioned you're familiar with UpToDate.
I am.
And UpToDate is a resource that is very widely known and used in the healthcare industry.
Yes, that's correct. It's an electronic form of medical knowledge that you can access both in hospitals and at medical schools to see what the latest information is on various topics.
Showing you what I've marked as Defendant's Exhibit Hans 24. Do you recognize this as it indicates it's up to date?
Yes, this is the format in which UpToDate would show up on our computers if we access it.
And this is actually a document that you were shown during the deposition. Is that right, Doctor?
That is correct.
Ethical issues in palliative care. I want to direct your attention, if I could, to how UpToDate defines the doctrine of double effect. I don't know how to get rid of the purple dots, but
You have to hit the clear button on the
they're
bottom.
joining us today.
Well, when people touch screens or they touch the areas, it happens.
Nope, I'm making it worse.
Okay, all right. Well, David, not to the rescue.
Okay, sorry. Down here, right?
So,
Yeah, down the
That's
bottom
right, okay.
and hit clear.
Which one's clear? Is this it, you think?
sure. Oh, I
I
don't know.
say X.
This?
Oh, it's an X.
Okay, I didn't want to push it.
No, me
Okay.
neither. Okay. So the doctrine of double effect, as defined by UpToDate, would you agree that the doctrine of double effects, it says, helps to reconcile that while an action may have more than one result, both an intended and an unintended outcome, it is still ethically justified as long as the intended benefit significantly outweighs the unintended harm. Would you agree that it says that sentence?
Yes, I would agree that accurately reflects that sentence.
And then it goes on to say, it being up to date. For example, giving pain medication to a dying person is justified, even if a foreseen but unintended consequence is that death is hastened. Do you see that?
I do see that, yes.
And this version of up-to-date appears, does it not, to be June of 2021?
Yes, it's June 19th of 2021.
And Dr. Ju, this has not been updated since then, right? There's not an updated version since June of 2021 that you know
I
of?
haven't looked to see if it is updated, so I'm not aware.
So then let me go to this page. Again, up-to-date, would you agree?
Correct.
Pain management at end of life, up to date. And up to date is a resource that is available to those in healthcare that they use or that you use in your course of practice. Would you agree with me?
That is correct. I use it both for practice and for teaching in the medical school.
You may. David? Okay.
I want to be clear, and certainly up to date. I showed you this as up to date is a resource for healthcare providers. Is that fair to say?
That's true.
And it is not a law book.
Correct, it is not.
But it is something, and certainly you testified in your deposition that you have access to as a healthcare provider,
Yes, I do.
that you can go to it and review it, and where you find applicable and appropriate, you can integrate it into your practice.
Yes, I would agree with that statement.
Because it is a trusted resource, at least in the industry.
Correct. Not every entry is obviously always accurate, but in total, it is a trusted resource.
Sure, and wouldn't you agree with me that everything is up to interpretation?
Correct. In medicine, where science changes regularly, it does require some art of medicine or interpretation.
So I wanted to clear up that I wasn't trying to say that this is the law. I just was asking about what up-to-date says with respect to doctrine of double effect.
Yes.
Okay. And then, secondly, with respect to the pain management and end of life, it up to date indicates, does it not, that sometimes in terminal illness, pain can go untreated or poorly treated. Is that fair? A fair summary of what it says?
Yes, the author of this article in Up to Date does make that statement.
And the author of the article in Up to Date then continues, do they not, and just says aggressive pain control at the end of life may be justified by the doctrine of double effect, which holds that medication intended to achieve pain relief is justified, even if it hastens death. Do you see that?
I do see that, but of course, again, that has to be balanced with the earlier statement that there has to be a proportionality. It can't just be that you give it irrespective of the outcome of the events.
Well, there has to be a good intention, right?
Correct. There has to be the appropriate intention, and the benefits must significantly, to use the author's words, outweigh the risks of the action.
You would agree that DNRCC, when that decision is made by family or next of kin, that the focus is no longer in treating the symptoms of the underlying organ failures or disease, right?
Yes, by definition, if a family and/or a healthcare surrogate decides to transition to DNR comfort care, then our primary focus is no longer to try to cure the underlying disease.
And the focus then shifts from that, from treating the symptoms and the disease and the multi-organ system failures, and it transfers to providing comfort care.
So I would agree that it provides symptom management in general, as well as providing comfort care. So you still control the symptoms, you just don't try to cure the underlying disease.
And that's the focus, right, of comfort care, is just as you described.
Yes, symptom management and achieving as best as one can the comfort of the patient while reassuring the family.
And we talked about that when determining the appropriate pain medication, medications to dose in a palliative extubation situation, it's not just pain. You also have to at least take into account, do you not, doctor, any kind of mental anxiety that the patient might suffer.
Yes, certainly that's the portion of the administration of the sedatives that would be aimed at controlling the anxiety or the agitation.
And then, of course, in situations where people are fortunate to have the love and support of family members, then there's also the extra layer of the family members that are witnessing this event.
Yes, that would be a secondary aspect of the analysis.
I forgot to ask you a question, but, well, you're not a lawyer, you don't have a JD.
No, I've not attended law school, nor do I profess to be a lawyer.
I forgot to ask you a question with respect to that, the rigidness you talked about that can happen with paralytics. Do you remember that?
Yes, stiff chest syndrome, also known as wooden chest syndrome.
Isn't there a setting on the vent that if I am experiencing stiff chest, that the vent actually alerts, the machine alerts?
So it is true that the ventilator has a high pressure alarm, that if the pressure goes up dramatically, it will give both an audible and a visual cue on the ventilator to indicate there's a problem. Unfortunately, in stiff chest syndrome, the chest and the lungs become so stiff, and even the upper airway can be involved, that you may not be able to get any air into the lung. So in that case, the alarm would not necessarily trigger.
But there is an alarm.
Yes, the ventilator has a fail-safe system to try to indicate to the doctors and nurses when there is a problem with the machine itself. That's true.
And then it is something, it's possible to visually observe that as well, is it not?
Correct. In stiff chest syndrome, the chest will not move. Even if you're squeezing the bag vigorously, essentially the chest becomes as stiff as a board, so then you will not see normal chest rise or fall.
And so ostensibly a nurse or attending physician or anyone at bedside, even a family member, if stiff chest was happening, it is something that could have been visualized.
Yes, if the person knew what to look for, again, certainly most families would have no understanding of what stiff chest syndrome was. In fact, most nurses don't even know what it is. It would really be an anesthesiologist or critical care physician who would know what that phenomenon was.
And I just want to, with lastly, Doctor, I think I went through all those records and just kind of want to summarize that we, in your review of these 14 patients, we saw progress notes from Dr. Mahoney,
True.
Dr. Dellinger,
Correct.
Dr. Clauser,
That is also a true statement.
Dr. Varghese, Dr. Iapin, is that right?
Correct.
Dr. Vashanini, Vacchianni.
I agree with that statement.
And in the ICU, Dr. Ralston,
Correct.
Dr. Fagan,
True.
Dr. Moody.
Correct.
We had the resident and the attending note from Dr. Battisti with Dr. Kim,
Correct.
Dr. Glucker,
True.
Deichel,
Correct.
Dr. Steichak,
True.
Chand, Dr. Chand and Dr. Hackett,
Correct.
Dr. Abraham,
True.
Dr. Gentile,
Correct.
Dr. Brady, Hess, Boo, I think part of that critical care team.
Yes, Brady was the attending, and Hess-Bow was the physician's assistant that first saw Miss Austin, I believe.
And then Dr. Brady just reviewed Ball's note.
Correct.
And then we had Wooten and Dr. Wooten.
That's correct.
Dr. Puntalinas,
True.
Dr. Patel,
Correct.
Dr. Gandhi, and Dr. O'Reilly.
Yes, Dr. Gandhi was a resident that wrote notes, and Dr. Riley was the kidney doctor.
Nephrologist, would you agree with me on that?
Yes, a kidney doctor is in fact a nephrologist. Just many people don't know what that term means.
And I know it seems clear, but I want to ask it so that it's on the record. During all of the events that you testified to today, with respect to any of these patients, you were not present for any of this.
That's correct. I do not have privileges at Mount Carmel West, nor do I have an Ohio State medical license, so I was not present at the time these patients were being cared for.
And can I assume that you actually never went to Mount Carmel West?
Correct. I've never stepped foot on the campus of Mount Carmel West.
Nothing further. Thank you, Doctor.
You're welcome.
Ms. Grubb?
Your Honor, do you want us to proceed right now?
Yeah, how long do you think you have?
45 minutes?
Do you want to, Judge, you want to ask if they're, I mean, we've been going at it. I need to go to the bathroom here.
Huh?
I don't want to unduly delay things.
You said an hour and 45 or 45 minutes? Ladies and gentlemen, I always promised you 5 o'clock. If we go a little longer today, is that going to cause anybody any problems? We'll take 10 minutes and then get into this witness done. Does that work for everybody? No head action down at this end. Does that work for you? Okay. Let's take 10 minutes. Everybody get a restroom break and we'll try to finish them up today. All right. Scruggs.
Thanks to all for this level of attention late in the day. Your Honor, Dr. Schweiger, ladies and gentlemen, counsel on both sides. Dr. Schweiger, have you ever suggested in this matter that the 14 patients reflected in these medical records were not critically ill?
No, in fact, the opposite. I've always maintained in review of these records that all 14 patients had multi-system dysfunction and were critically ill, and certainly they were justified to be admitted to the ICU at some point in their hospitalization.
In your experience, do patients have some hope of recovery after being on life support, including vasopressors and ventilation?
Yes, absolutely. The fundamental premise of critical care physicians is to support patients with the breathing tube, with the ventilator, and with the vasopressors so that the treatments to correct the infection or other diseases can be brought under control. Otherwise, we wouldn't really have any goal of working in the ICU. Many of the patients that are offered these treatments do in fact survive and are able to leave the hospital.
Is it protocol in your hospital or in your practice to determine the effect of paralytics prior to a palliative extubation?
Yes, in our hospital, it is always the protocol that you must determine the effect of the paralytics prior to even considering a palliative extubation, and to give ample time, being 3 hours prior to being allowed to pull the tube without worry that there could still be residual effects of the paralytics, which could prevent the patient from breathing.
Thank you. You sure? Yeah, I understand. So I just want to proffer it and then look. Yeah. Can we sidebar, Your Honor?
You ready there, Madam Court Reporter? May proceed.
I'm sorry. Didn't mean to step on you, Judge. Doctor, does obesity rate as a factor in determining how much to dose fentanyl?
Yes, since fentanyl should be dosed on a weight proportional dosing, obesity most assuredly does impact the dosing. But then also a major safety factor is, since obesity impacts both the upper airway and the lungs, there should be an appropriate reduction in the dose of fentanyl for concern that the obese patient would be more sensitive to the effects of the opioids.
Just so I understand this, I mean, this goes contra. Did I just hear that the larger the patient, the less rather than the more?
Yeah, so in many medications in the ICU, if a patient is larger, you would give them more. However, with opioids, and particularly with fentanyl, because of the concern of respiratory distress or the patient becoming apneic, you would actually want to reduce the dose of the fentanyl and the opioids to avoid respiratory depression.
Thank you. Did you check Glasgow and RAS scores in these patients?
Yes, when the Glasgow and RAS scores were documented by the nurses, as well as the CPOT score for pain, I did look at those and include that into my analysis.
Thank you. Doctor, irrespective of when a discussion may have been made with respect to a code status or withdrawal of care, is the physician who is overseeing that withdrawal of care ultimately responsible for all the decisions made on that withdrawal?
Yes, the physician that is overseeing the terminal extubation and the transition to withdrawal support is ultimately responsible for the acts that will then follow, as well as placing the appropriate orders in the patient's chart that will essentially guide the nurses and the respiratory therapists on how to proceed with the comfort care measures.
Does that include dosing?
Yes, absolutely, because it is the physician who determines the dosing. Nurses are not allowed to prescribe. They depend upon the physicians to enter the orders on how the medication should be dosed, and then that's confirmed and checked by the pharmacist.
Turning to Bonnie Austin, you testified before that she had a pacer that paced at 70 beats. After that pacer was removed, what happened?
So, because as part of the palliative extubation, she had received the medications that we've discussed, obviously her heart rate went down, and then eventually she arrested.
And did it ever hit 40 beats per minute?
The pacer? No.
No, her heart.
Yes, her heart rate did.
Is that survivable?
Yes, bradycardia at that rate, of course, can be survived. Again, it depends upon the oxygen requirements of the patient. So again, certainly a heart rate in the 40s sometimes can actually be beneficial, particularly if there's valvular heart problems.
Thank you. Can low pH or high pH be altered?
Yes, both low pH and high pH can be treated by critical care physicians, both with medication that can be administered, such as sodium bicarbonate, and by purifying the blood of the acid in the system through the use of various forms of dialysis. And then very rapidly, we can adjust the pH by increasing the amount of air that comes into the lung so that carbon dioxide is blown out. So all three of those techniques can be used to normalize a patient's pH.
Can people who are on vasopressors survive and breathe for some period of time?
Yes, absolutely. Critical ill patients who are either reduced or taking off vasopressors can survive for prolonged periods of the time. And in fact, many times it may surprise the physician as to the duration of their survivability once those agents are weaned off.
Doctor, do you stand by any corrections that you've made in your reports?
Yes, that's correct. The corrections that have been noted during the last 3 days of testimony, I do stand by, but the vast majority of the content in those extensive 14 reports that I wrote are correct and accurate and reflect my review of the medical records.
Turning now to Mr. Timmons, is it your testimony now that the surgery for him lasted 36 minutes?
That's correct. Based upon my review of the anesthesia record, which is similar to the one that we use at Tampa General Hospital, so I am familiar with it, it indicates that the surgery is relatively quick. And in fact, that's my experience with fasciotomies. You usually can achieve the operation between 30 and 45 minutes, particularly if you're only going to do one limb, like the lower extremity.
Is it your opinion that it is highly unlikely that 14,000 micrograms of fentanyl was used in that 36 minutes?
Yes, it is technically impossible that that could have been given during that form of an anesthesia. It has to be some either form of computer glitch that incorporated the total amount that he received during the hospital.
speculation as to a computer glitch, or that it couldn't have been given?
Sustained.
Move the strike.
Strike.
Thank you.
Thank you.
What do you know about the National Academies of Sciences, Engineering, and Medicine?
I personally don't know anything specifically about it. I'm aware that it exists, but I've never been a member or asked to join it, so I have no experience with that organization.
Defendant's Exhibit Hans 23 was discussed. Cardiac survival rates around 6%. In your professional opinion, do you believe that this is a peer-reviewed article?
I can say definitively this is not a peer-reviewed article. This is basically almost like a news release update from the organization. So this is not something that I would provide credible data or expect credible data from, because it's not peer-reviewed.
What is a peer-reviewed article?
Peer-reviewed article is when the authors submit their scientific research for rigorous evaluation, both by editors from the journal, and then those editors submit it to experts nationally in that field to review it and look for scientific validity. The article can then be accepted or accepted with corrections, which would then require the authors to rewrite the article. But this was not peer-reviewed.
What is system derangement in medical terms?
System derangement means when the normal function of the body or one of the organs underneath it, such as...
Your Honor, objection beyond the scope.
Your Honor, I believe that system derangement definitely applies to many of the patients.
What is system arrangement?
System derangement is when the normal function of the body or the organs is disturbed and then gets out of balance.
May I develop, Your Honor?
You may develop.
Did Ms. Menashe's cross-examination touch on patients that had system derangement?
Her cross-examination did touch on the topic of system derangement of the various organs of the 14 patients under review.
Thank you. What would you recommend for the patients that had system derangement?
In patients that are either transferred or admitted in the ICU, that they receive appropriate therapeutic interventions to stabilize those organs and the system derangement, and give an ample amount of time to allow the patient and the patient's body to declare itself before definitively concluding that the patient is terminal or that any further additional treatment would be futile.
Thank you. And what is that period of time that you normally recommend?
Normally, for critically ill patients, I recommend 72 to 96 hours, so 3 to 4 days, in order to determine the efficacy of the treatments we're providing to correct the underlying imbalance in their body.
What is your opinion regarding the emergent nature of any of the extubations discussed in these cases?
In my professional opinion, none of the 14 cases warranted emergency terminal extubation or rapid removal of life support because, again, they appeared to have issues that were still active and would have benefited from either further symptom management or continued treatment of the patients.
Why is it medically appropriate to extend all reasonable measures to patients like the ones discussed in this case?
It is medically appropriate because even with the best attempts of a physician to provide appropriate assessment and plan, doctors are never 100% sure of the outcome of any given patient. So doctors should always err on the chance or the side that the doctor himself or herself may be incorrect in a diagnosis. And by allowing that patient enough time to declare themselves, you can then essentially allow those patients who can still survive the opportunity to demonstrate that their organ function can in fact return.
Thank you. Do you have any opinion opinions which may have changed as a result of the questions posed by defense counsel?
No, the questions that were posed to me today by defense counsel have not changed in any way the opinions that I have formed after the careful review of all 14 medical records.
Did defense counsel bring forward any factors which would change your opinions as to the appropriateness of the drugs administered to the alleged victims at extubation?
No, none of the issues that I've discussed today or been asked to testify impact my opinion that the doses that were ordered for these 14 patients and the various selection of both opioids and the Versed were dramatically in excess of anything that could have been justified to facilitate an appropriate terminal extubation. And in fact, it is still my opinion that they caused and or contributed to these patients' deaths.
Do you agree with the version of the doctrine of double effect that was presented here this afternoon?
No, one must always understand that you have to demonstrate an appropriate balance between the benefits of any treatment versus the potential risks. And if the potential risks are catastrophic and would imminently result in the death of the patient, then that cannot just be blanketly supported by the doctrine of double effect. Otherwise, any doctor on any given day could really do whatever they want and then use an escape hatch of saying, well, it was just the doctrine of double effect. You have to use moderation and proportionality when you're examining whether or not it can be justified.
One moment, Your Honor. That concludes my examination, Your Honor.
Thank you. Ladies and gentlemen, I'm going to send you home. They actually did it before 5 o'clock. I want to discuss one thing first. Just relax. They're not out the door yet. Tomorrow, we're going to go to like 11:25. I've got a Zoom conference I have to attend. Okay? And then we'll come back and start back up at 12:30. We'll do the breaks. It's my understanding from my notes that one of you has a plane to catch and that I heard today that someone else is helping them out. So we're going to quit at 3:30. Okay? You can plan accordingly. Okay? Y'all look at me like I'm crazy. What? Huh?
Can we get the witness Judge, he's got a light. Can we just get him off the stand?
I need to talk to him.
Oh, okay, I apologize.
Okay? Okay, ladies and gentlemen, remember the admonitions. That'll be the schedule tomorrow. 9 o'clock, let's get started. David?
That's what they gave.
Have a good evening, guys. Hopefully it's cooler tomorrow. Gonna be seated. For the record, I will be facing a decision about admissibility. I think it's necessary for the record to reflect the questions that I'm going to ask, since there will be issues in the future. Doctor, did you have any guidelines on how to prepare your reports?
I did not know.
I reviewed one. No one told you about standards or anything?
That's correct.
Okay, now, in reading, I've only read one, that being that of Sandra Castle. Did you basically take your medical malpractice case and convert it over?
I was not involved in the medical malpractice case of Sandra Castle specifically. I was retained on the Bonnie Austin, Danny Millette, and then I went to deposition, information on Sandra Castle was presented to me by Mr. Schweiger.
Okay. So you never did a formal report in the med mouse?
I did one in the Austin and Millette case, but not in the Castle case.
Okay. In the two cases that you just alluded to, did you basically transfer the concepts of the med mal over to the reports found within the exhibits?
Initially, I did, and then subsequently, I started to change that methodology, so in the later reports, it was not predicated on the med mal review.
Okay. Anything based upon my questions?
No, Your Honor. Okay, hold on, I guess, Mr. Zion. Mr. Zion. Did you do an independent review of all of these cases to submit these reports to the court?
Correct. Two separate independent reviews. The first, before my first report, which was, I believe, 14 or 15 pages, that just looked at the general topics in the case. I didn't break down each specific case. And then subsequently, I was asked to write individual reports on the 14 cases that I had been told were under review, that I should subsequently go back and do a re-review of those cases.
Okay. Anything else?
Yes, Your Honor.
Hold on. I would finish with this side.
Oh, sorry. No.
Possible question.
Oh, no. Oh, sorry.
Nothing further, Your Honor.
Ms. Menashe.
Yes, referring you to your deposition of January 21st, 2021, page 78. I want to give it to Ms. Grubb first. I want to read it exactly, so just give me a minute. And that deposition was June 21st of 2020.
That's correct.
Do you remember being asked in that deposition, question, okay, and what did the prosecutors ask you to do? And you answered, they asked me to review various records of patients who were at Mount Carmel West and render an opinion whether or not Dr. Husel had practiced within the applicable standard of care. Do you remember that answer?
I do remember that answer, yes.
Then the next question, did they ask you to form an opinion of his mental state and tension? You answered, did you not? Yes, as part of the violation of standard of care, whether or not he intended to simply alleviate pain, or whether he, based on the medical records, he intended to hasten the patient's death. Do you remember those answers?
I do, yes.
I'm happy to approach if you want to refresh or think that that's not accurate in any way.
That seems to be my answer back in the deposition.
Your Honor, I would just like to mark this. If we-
Okay. Why don't we mark it as Court 12,
If you,
since it was my inquiry?
yeah, thank you. Appreciate it.
It's not going to be part of anything that goes to the jury. Anything else for the doctor? Let's let him catch his flight. Yes, Ms. Grubb?
Thank you. I just want to ask the doctor, were you referring to a medical standard of care?
Correct, a medical standard of care, not a legal standard of care.
Thank you.
Okay. Thank you, sir.
Thank you, Your Honor.
You're excused. Ms. Grubb, anything for the record?
Nothing.
Well, one supplemental report.
Yes, okay. One final question. When did you pen the supplemental reports?
The supplemental reports were then penned after the independent review, so those were penned I believe, in early 2021. I'm sorry, 2022 is this year, so it's this year.
As an officer of the court, I can indicate that's correct.
Okay.
It's 2022.
Anything else before I let him go?
No, Your Honor.
Doctor, you're excused. Run quickly.
Thank you.
He's going to want to hand you this stuff back. Is that our stuff?
That's yours. Thanks so much. Have a safe flight. And maybe go to the airport lights and sirens. That'll be exciting.
Okay. Anything for the record, Ms. Grubb?
Not right now.
Menashe?
What?
Anything for the record?
No, yeah.
Okay. Have a good evening, guys. I've got that thing.